já, obrigado pela presença. Que venha a pena o tempo e a deslocação que tiveram para assistir a esta pequena reunião. Vai-se dividir em três partes. Vamos falar um bocadinho da cirurgia, tentando ver um pouco o futuro. Seja muito pontual, porque há problemas de regresso com aviões. Portanto, eu pedia que nos coffee breaks, nos almoços, a coisa corresse dentro dos tempos. Vamos começar com a pessoa que eu penso que será das que mais bem de alinhamentos. Já trabalha com e junto de pessoas que têm desenvolvido várias teorias. O Corte ia chamá-lo para a apresentação.
Thank you, Dr. Sousa, for the introduction. It was in Portuguese. I don't understand Portuguese, so I hope it was not. Thank you very much for the invitation. It's a pleasure and an honor for me to be here. I was asked to give an overview about the alignment philosophies, the different alignment philosophies which are available. And I think if I look at the room, probably most of you have been trained with mechanical alignment. But during the history, we have seen that other philosophies also came up. And the reason why people were thinking about different philosophies was that we saw that with mechanical alignment, if you combine that with symmetrical implant, in most of the cases, if you do the surgery, you change the anatomy of the knee. And we know with mechanical alignment, we have a good survivorship. But if you look at the clinical outcome, then we also know a lot of studies about that 15 to 20% of unhappy patients, that this is less good. So with all these new philosophies, people try to come closer to the normal anatomy and try to improve the functional outcome. So before we're going to go and look a little bit more into detail on some of these philosophies, I just want to highlight two parameters which are really very important if you're going to talk about alignment and CPEC during the day. And so the first one, this is what you all know, this is so the hip, knee, ankle axis. So this is giving us a neutral or a valgus or a varus leg. But also very important is the joint line orientation. And so if you look here at the hip, knee, ankle axis, and you're going to refer to the vertical axis, so the vertical axis is the axis to the middle of the body, perpendicular to the ground, then you see that these two axes, they are not parallel to each other. So there's a small inclination of about 3 degrees. And the reason for that is the way that we are built. So the pelvic, it's a little bit wider than when you put your feet on the ground. If you look at the knee joint on itself, then you also see that the joint line here, it's also not perpendicular to the mechanical axis. Also here, we have an inclination of around 3 degrees. This is what we call, by way of saying, the 3-degree varus joint line. So we learned from Kapanji that, in fact, these two inclinations of 3 degrees, they're going to neutralize themselves if you're walking or if you're standing in rest with the feet together. So then you see that if you look at your joint line, the joint line is parallel with the ground. So your joint line orientation becomes parallel with the ground during walking and if you are in rest. Important if you're going to talk about joint line are these two angles that we have here. So we're talking about MPTA and LDFA. Probably most of you know it, but just to be sure that everybody know what it means, MPTA, so this is what we call the medial proximal tibial angle, and this is formed by the mechanical axis of the tibia and the joint line of the tibia. How are we going to find the joint line of the tibia? Well, we're going to take the deepest points on the medial and on the lateral plateau, and we draw a line between these 2 points. On average, MPTA, this is around 87 degrees. So again, this is what we say, the 3-degree varus joint line. If you look in the other direction, this is where we find the LDFA. So this is the lateral distal femoral angle, and this is formed by the mechanical axis of the femur and the joint line of the femur. How are we going to find the joint line of the femur? Well, we take the most distal points on the medial and the lateral condyle, and we draw a line between these 2 points, and that's the joint line of the femur. On average, this is around 88 degrees, so 2-degree valgus in the femur. So we are talking here about 2 joint lines, the joint line of the femur and the joint line of the tibia. And in most of the cases, like you see over here, they will be rather parallel. So there will be a difference here of 1 degree between the two. And this is what we call the joint line convergent angle. So that's the angle between these two joint lines. And this is normally between 0 and 2 degrees in most of the cases. All right, so saying this, we can have a look at the alignment philosophies. And of course, we need to start with what we learned in the 70s, what Mr. Insel taught us, and this is mechanical alignment that probably most of you have been doing for many years. So typically on mechanical alignment is that we're going to make the leg straight every time. So that's the goal, making the leg straight. And you see that we're going to make the cuts on the tibia and on the femur perpendicular to the mechanical axis. So the reason for doing that is that we want to have a good loading of the implant and of the bone underneath the implant. And because of this, that we have that good loading, we know that we have a great survivorship if you're going to use mechanical alignment. So if you look at it, tibia, this is the cut perpendicular to the mechanical axis, perpendicular on the femur to the mechanical axis, so this is going to give us the rectangular gap in extension. If you look in flexion, of course, it's the same tibial cut that we have over here, but to have that rectangular gap, we're going to give external rotation in that femoral component, most of the time around 3 degrees external rotation. So by giving external rotation, if we cut in that way and we're going to put a symmetrical implant there, we're going to lateralize the trochlea of the femur. And that's going to help us to having a good patella tracking. So this is typically for mechanical alignment, but also with mechanical alignment, in that technique are some disadvantages. So one of the disadvantages is that we probably, in a lot of cases, going to change the height of the joint line. On the tibia, most of the time, this is going to be on the medial side, so depending on the wear and the amount of bone that you're going to cut away. On the femur, probably this is going to be most of the time on the lateral side. I think you all know the situation when you're going to do your distal cut, and on the medial side you cut 9 millimeters, but on the lateral side you cut only 6 or 7 millimeters, or in valgus knees 3 or 4 millimeters. But you're going to put back 9 millimeters of metal. So that means you might overstuff your joint there on the lateral side. And it's not only the height that we're going to change, but we're also going to change the joint line orientation. So you see it very clearly. If you look here at the perpendicular cut that you have on the tibia and on your femur, you see that the joint line that you have here, if you put a symmetrical implant in place, this is not parallel anymore with the floor. So you change, in fact, your anatomy at that moment, especially with references to the attachment of your ligaments. We're also going to make the leg straight, we said, and you're going to do that every time. That's what you try to achieve, but also in case that the patient coming in with a varus or with a valgus. And we know now, in the latest years, that this is not always the best possible thing to do. So because we change the anatomy of the joint line and the joint line orientation, and we change the overall alignment in some cases, we often have to do some releases to balance the knee to have a good outcome. So this is about mechanical alignment. So the first group who didn't agree with mechanical alignment was a group around Krakow and Hungerford, and they starting to promote anatomical alignment. So what was typically for anatomical alignment? Well, they also wanted to restore the leg straight, so they also wanted to have a straight leg as outcome, but they didn't cut perpendicular on the mechanical axis on the tibia and on the femur. They wanted to restore the joint line orientation. So we said that on average this is around 3 degrees. Well, what they did was they always, for every patient, they cut 3 degree varus on the tibia. So if you cut 3 degree varus on the tibia and you want to have that rectangular gap in extension, you also have to follow on the femur. So that means instead of having a neutral cut, most of the time 5-6 degrees, here you're going to add 3 degree valgus. So you're going to cut 9 degree valgus on the femur to have that rectangular gap in extension. And in flexion, of course, again, we have the same cut, so 3 degree varus cut on your tibia. To have a rectangular gap in flexion, you cannot give external rotation on that femoral component, because if you would give external rotation, referring to the posterior condyles, you would open more medial and you would close it lateral, so we cannot do that. So this is why we have to cut neutral posterior. So if you're going to cut neutral posterior, that means that your trochlea is not going to be lateralized, but rather medialized. So disadvantages of this technique was We see it here, the varus cut that you make. And you have to think back, we are talking here about the 80s. So that means that the instruments that they were using at that time, they were not so accurate as the instruments that you have now. So you can aim for 3-degree varus, but you can easily end up with 6-7 degree of varus, easily to make a mistake. And the second thing is that the quality of the polyethylene at that time was also not as good as the polyethylene that we have now. So by doing that cut, 3-degree varus, they saw a lot of problems coming up and a lot of publications came out. And some examples are here. So you see subsidence of the implant into the bone, because if you go for varus cuts, your loading of the bone is completely different than if you do a neutral cut, of course. So subsidence of the implant into the bone, wear of the polyethylene, and we saw that if you have a patient who is obese, then the risk of having that problem is even higher. And the same if you go away from the 3-degree and you end up at 5 or 6 degree, then you see that the forces are to almost 50% higher than if you have a neutral cut. A second problem that we saw, we mentioned it here, neutral position of the femur, so also problems with the patella tracking. And due to these two problems, tibia and the patella tracking, a lot of people stopped using anatomical alignment, and they lost, in fact, the battle against mechanical alignment, and mechanical alignment became the golden standard for many years. Until 2008, when we have Steve Howell coming on meetings and starting to talk about kinematic alignment. So what is kinematic alignment? Well, it's in fact just the opposite of what we learned from mechanical alignment. So what you see here is that they're going to restore the joint line orientation. So you can say, yeah, this is just the same as anatomical alignment. No, it's not. Anatomical alignment, they're always going to cut 3-degree varus for every patient. Here, it will be depending on the patient. It can be 3 degree, but it can be 1 degree, 5 degree, 7 degrees. They're also going to restore the overall alignment. So if it's a neutral, they will put it back in neutral, but when it's a varus knee, they're going to put it back in varus, valgus in valgus. And so by doing that, not changing the joint line orientation and not changing the overall alignment, they don't want to touch the ligaments. So they don't want to stay, they want to stay away from the ligaments. They don't want to do any ligament release. So this is one of the first times that people are starting to talk about bringing back that individual implant position. I also want to highlight a little bit more on the picture that you see over here. So this is more, I call that more a theoretical aspect, but I want to explain this a little bit, because if you're going to read or look at something about kinematic alignment, these pictures are going to come back every time. So what these people are saying is that there are 3 axes in the knee, and you don't want to change the position of that axis, of these axes, because if you're going to change them, then you're going to change the kinematics of the knee. So it's important to keep these axes on the correct place. So you have the green axis that you see over here. So this is going through both of the condyles of the femur, and this is the axis where you have the tibia moving from flexion to extension around the femur. Parallel with it, a little bit anterior, you have the purple axis, and this is where you have the trochlea, where you have the patella tracking in the trochlea. And the third axis is perpendicular to the other two. It's the orange that you see over here. And this is where you have the tibia underneath the femur going in internal and external rotation. So if you want to keep these axes in the correct place, there's only one way that you can do your surgery. And this is what they are calling resurfacing of the bone. So you're going to look at the thickness of the implant. If this is 9 millimeter of metal, then they're going to cut away 9 millimeter of bone. So they're just going to replace the bone by the metal, the same thickness. And in that way, they try to keep the same shape as close as possible. So they do that distally, posteriorly, and on the tibia. They're going to look at wear. So if you have wear, they're going to compensate for 1 or 2 millimeter of wear. So if your implant is 9 millimeter thick and you have a lot of wear, they're going to say we have 2 millimeters of wear. They're only going to cut 7 millimeter in these cases. They're also going to check during the surgery every step that they are doing. And they do that by measuring the bones that they cut away. So if your implant is 9 millimeter thick distally, they're going to cut 9 millimeter of bone if there is no wear, and then they're going to measure the thickness with a caliper. And you should measure 9 millimeters minus 1 millimeter of the saw blade. That's 8 millimeters that you should measure. So this is why they call it also the caliper technique, that they're going to measure every cut that they are performing to check if they are correct. So also in this technique, you have disadvantages. First of all, the theoretical aspect that I was explaining you around these axes, it's very difficult to find these axes and to keep them in the same place. They tried to do that by working with a kind of a patient mat cutting blocks, but that failed. So that was taken from the market. And even if that should work, if you really want to keep these axes in the same place, I think you should work with a custom-made implant and not with a symmetrical implant. Because if you're going to put back a symmetrical implant, you will have a lot of places where you have too much metal and other places where you don't have enough metal. So that's a concern about these axes. We talked about varus cuts with anatomical alignment, going to 3 degrees and looking at the problems. Well, if you look at this case over here, here you have an 8-degree varus cut on the tibia. I think a lot of you would really be afraid of having an 8-degree tibial cut. So the problems that they have seen with anatomical alignment, also here, a lot of people are afraid that the same can happen if you're going to do these varus cuts. The same is related to the patella, because you're in flexion. If you're in varus on your tibia, you're going to be in neutral or internal rotation on your femoral rotation, and this can give you problems with patella tracking. And the last topic that people are a little bit afraid of is if you follow the protocol during the surgery, after the cuts, they're going to balance the knee. You can do that with spacers or with your trial components, but as I said before, if it's not well balanced, they're not going to touch the ligaments. They want to stay away from the ligaments. So it means that they're going to restore that by doing recuts on the tibia. So the more you're going to cut on the tibia, the lower you come, and the higher the risk that your knee becomes unstable, especially on the medial side. So these are the disadvantages for kinematic alignment. So when they're starting to talk about that, and you probably have been to these congresses, there was a lot of discussion, a lot of questions, and a lot of uncertainty. And there's a lot of studies that has been published around kinematic alignment. I can show you the studies where we have the varus cuts on the tibia, but another concern, as I mentioned, was around the tibia. Well, this is a recent study where they looked at a group of patients done with kinematic alignment and with mechanical alignment, and they looked at the tilting, and then you see that you have much more tilting in the group with kinematic alignment, 13%, than you have in the group with mechanical alignment. If you look a little bit at the studies, then you see that you have also studies saying that it is as good, kinematic alignment is as good as mechanical alignment. This is one of the examples here that they compared 2 groups in the short term, 1 year postoperative, looking at all kind of prompts that you have over here, and there was no different. But why I selected this study was because of the take-home message that they put into the conclusion here. And so they are saying, we do have the same results here, but we do not know a lot about long-term. So be careful. Why should you use it if we're not sure about the long-term benefits, long-term risks? They assume that there is 1 or 2 millimeter cartilage thickness, but is that the case? Sometimes you probably have 3 or 4 millimeters cartilage thickness. They say that they have no bone wear. They don't calculate for bone wear, but if you see this case, I think you have bone wear, patella tracking, deformity, so how far can you go here? So all these discussions make people think. This is a study where you see that they are even better with kinematic alignment than with mechanical alignment. But if you then look into details, and this is the outcome of the study that you see over here, then it's a little bit confusing because you see, if you look at the overall alignment, in the group of kinematic alignment, it's 0. And with mechanical alignment, it's even a little bit of varus. And if you look at the MPTA and the LDFA, the cuts that they make, it's 2.5. Well, this is in fact anatomical alignment. And this is mechanical alignment. So are they comparing the same or not? So with all these things, a lot of confusion and a lot of questions. But again, it makes people think, perhaps we should go a little bit in that direction, but be a little bit more careful. And that study is in fact showing a nice summary of all the discussions that has been ongoing before. So they are saying that if you perform mechanical alignment, you're focusing fully on the biomechanics, but in fact you forget a little bit the soft tissues because you have to do, in a lot of cases, soft tissue releases. If you're going to do kinematic alignment, you're perhaps focusing too much on the soft tissue. You don't want to touch the ligaments, and you forget the biomechanical aspects. So perhaps the best solution here is what they call a hybrid technique, or something between the two. And then you start looking at a kind of a safe way where you can work in that you don't sacrifice the longevity of the implant. And so this is where all the other alignment philosophies came in. that you're going to see a little bit more into detail. So what they want to do here is really working, but in a safe environment, not going to cases like we saw 8 degrees of Ferrous, but stay within limits. And then a lot of people are going to use these kind of studies as a kind of a reference. What are the safe limits? So if you look at it, the hip, knee, ankle angle X that we set, so they go to 3 degrees varus or valgus. That's the maximum. And if you look at the cuts that we make on the femur and on the tibia, so the MPTA and the LDFA, in fact, they're going to do that between 5 and neutral, so between 85 and 90 degrees. So this is what a lot of people accept as the safe limits. So one of the first guys who was talking about that was Johan Bellemans, and he brought it up when he looked at constitutional alignment, and he published around constitutional alignment. So what is constitutional alignment? Well, he looked at a big group of healthy persons. They were between 27 and 30 years old, so at the end of the skeletal growth. And he measured a lot of parameters and also the overall alignment. And he found out that looking at these 500 persons, that only 15% had straight legs. So that means that 85% of that group, healthy people, were in varus or in valgus and not having straight legs. And most of them were in varus. So it means that if you have a patient who is in 3 degrees of varus at the end of skeletal growth, and he becomes 70 years old, he has been 70 years in the position of varus. So if you're going to change him at that moment to mechanical alignment, in fact, this is a kind of an overcorrection that you're going to do, because he has never been in that position of a straight leg. And that's why you have to do releases to correct the balancing over there. So Bellemans is saying you should leave these patients then in varus or in valgus, but again, within limits. And he is talking here about 3 valgus, 5 varus, and the cuts that you make on the tibia, maximum 2.5 degree varus. Also here, disadvantages, the same as what you have seen with kinematic alignment, but less, because they're more strict, they're not going so far. But Bellemans wanted also to solve these problems over here. And he did that by, instead using a symmetrical implant, changing to an asymmetrical implant. So he brought an implant on the market that is asymmetrical. And that means that if you look at the medial side of the femur, it's bigger, condyle is bigger than on the lateral side. And if you look at the insert, it's higher on the lateral side than on the medial side. So in other words, if you look at it, your 3 degree joint line, it's built into the implant, into the component. So that means that he can solve the problems that we have seen before. He can cut perpendicular to the mechanical axis of the tibia. The joint line, you see very nice, is parallel with the ground because it's built into the implant. And if you want to leave a little bit of varus or valgus, you can do that in the femur. So he's leaving varus or valgus in the femur, 1, 2, or 3 degree. And then you have an overall alignment of 1 or 2 or 3 degree. Another philosophy that came up, logically, this was Van Titolle, who published around restricted kinematic alignment. And this is, in fact, just the same as kinematic alignment, but within these limits. Yeah? So if you look at the principles that they have over here, overall alignment should be within 3 degree varus or valgus. The cuts that you make should be within 5 degree, between 5 degree and neutral on the MPTA, the LDFA. They don't want to touch the ligaments. They don't like to do that. They stay away from the femur. Remember, the same philosophy, these 3 axes, they don't want to touch that. So that means if they have to redo something, they will have to go to the tibia to redo some, to make new cuts. And it's also a resurfacing technique, so very close to kinematic alignment, but really within safe limits. Disadvantages, same that we see before. So if you have to cut 3 degree with conventional instruments, not always easy to do that, and varus cuts and neutral or internal rotation of the femur can lead to problems with patella tracking. The last I want to highlight is functional alignment, and this was published in 2020 by Lustig. And typically for functional alignment is that this is always in combination with new technology, always. So you're going to use patient-made cutting blocks, or you're going to use robotics. And so that means that you will have a planning, preoperative or peroperative, that you can check before you're going to do any cuts. So you can look at the alignment, you can look at the joint line orientation, but if you do robotics, you can also look at your ligament balancing. Remember, with constitutional, if they have to change something, they're going to do it on the femur. With restricted kinematic alignment, they're going to do it on the tibia. With functional alignment, they can fine-tune both. So if you work with robotics, you can fine-tune up to half a degree, half a millimeter on the femur and on the tibia, and you see immediately the consequences. So this is functional alignment. Just a few remarks. I didn't talk about inverse kinematic alignment, not to make it too complicated. Inverse kinematic alignment, this is when you start from the tibia and then go to the femur. You're going to use a kind of a balancing system, a little bit, for those of you who know LCS, a little bit in that system, starting from the femur and then go back to, from the tibia and then go back to the femur. In the meantime, most of the companies, they have their own alignment philosophy. I think I can say that all of these alignment philosophies are the same as functional alignment. They just give it their name together with their robotic system. But all of them are in fact functional alignment. The boundaries that we talked about, 3-degree overall alignment, more and more people go away from that. So more and more people go to 0 or 1 degree valgus. They're a little bit strict in valgus, but some guys already go to 4, 5 degree of varus. So this is personal. Think about it, your bone quality is also important for your boundaries. If you have a poor bone quality, I'm not sure if it's a good idea to do 4 or 5 degree varus on your tibial cut. And the last remark I want to make is that we are talking here, and everybody is talking about this, about cemented implants. But some companies are pushing hard to get cementless implants. And we all know that if you have cementless implants, you need a good fixation to have a good bony ingrow. This is a study that has been published. And this is the consequences if you have 2-degree varus on your tibia. So then you see during the walking cycle that you have 16% more micromotion of the tibia during walking. So be careful if you use cementless implants and you think about going to another alignment philosophy. There's not a lot of results about that. So think twice, I think, if you're going to do something there with cementless implants. So that's it. This is what we have seen, mechanical alignment, the golden standard, making it straight, perpendicular cuts, lateralization of your patella tracking, good survivorship. Anatomical alignment came up. They cut 3-degree varus for every patient and 3-degree valgus more on the femur, but they lost the battle due to the problems with tibia and patella tracking. Kinematic alignment came up, just the opposite. So they're going to restore joint line orientation, they're going to restore overall alignment, and they wanted to stay away from the ligaments. They don't want to touch the ligaments. So a lot of people were afraid of the limits on this, and this is why all the other philosophies came in that we've seen, like constitutional alignment, in fact, coming from kinematic alignment, but staying within the limits, 3-degree overall alignment and 5-degree cuts on the femur and on the tibia. If you have to do something, you do it on the femur. With restricted kinematic alignment, if they have to do something, they do it on the tibia. And with functional alignment, then they're going to do it on both, because they can really do it very, very controlled, because they have new technology to help them. Thank you. Thank you.
Justified coming here today just to you can go home now.
Thank you.
Okay. So now I call Levi Fernandes that will talk about technologies in preoperative planning.
Bom dia a todos. O meu nome é Levi Fernandes e eu faço parte do grupo de joelho de cirurgia da CUF em Santarém, juntamente com o Dr. Manuel Oliveira e Gonçalo Martinho aqui presentes, mas também o Dr. António Júlio. E gostava de agradecer o convite do Dr. João Paulo Sousa para vir aqui falar um bocadinho sobre planeamento e sobre o que é que nós estamos a fazer em Santarém, mas também um novo algoritmo que eu desenvolvi com a PicMed, especificamente para o planeamento das próteses totais do joelho. Portanto, basicamente, nós começamos isto de forma manual, no início deste ano, de forma mais sistemática, a registar todos os ângulos dos nossos doentes e a planear a prótese segundo o alinhamento constitucional e segundo a teoria do professor Michel Bonin, com quem tivemos em dezembro, e associado a isso, começamos a fazer também o templating sistemático das nossas próteses. Depois disto, no fundo também para responder um bocadinho às exigências dos cirurgiões que trabalham com a PICMED e que acabavam por querer ver outras filosofias incluídas no sistema que não só o mecânico, que era o que nós tínhamos até agora, e principalmente porque queriam ter independência e poder fazer o planeamento de forma autónoma. Nós desenvolvemos então este novo algoritmo que, além de ter todas estas filosofias de alinhamento incluídas, é possível depois integrar com todas as outras tecnologias associadas, nomeadamente na parte da execução. Queríamos que fosse automática para ser rápida e depois tivesse um pequeno componente educacional que permitisse também aos cirurgiões que estão a começar terem mais facilidade em perceber estes novos conceitos. Então, como é que isto funciona? Basicamente funciona passo a passo, que nós começamos com uma análise da deformidade e a sua classificação por fenótipos. Depois, então, o cirurgião escolhe qual é o alinhamento com que mais se identifica, ou que acha que faz mais sentido, e nós aqui temos as opções, para já, do kinemático, do mecânico e do constitucional. Depois o cirurgião escolhe, então, depois de escolher o alinhamento, escolhe quais as ferramentas que tem para atingir esse alinhamento, quais é que são as armas. E, por fim, então, tem o plano feito da cirurgia e depois é um bocadinho necessário fazer a confirmação do resultado para perceber se isto está a funcionar. Começamos sempre por perceber quais é que são os ângulos importantes, então, para o nosso doente e qual é o fenótipo desse doente, para responder à pergunta que é como é que eu consigo dar ao doente o melhor resultado possível e que irá funcionar melhor para ele. Portanto, a primeira fase é relativamente simples, já é familiar para muitos de vós, sobretudo porque existem noutros programas também, como o programa de osteotomia. Faz-se uma marcação dos pontos baseado no raio-x extralongo. Esta marcação dos pontos é facilitada por estes diagramas que têm depois uma legenda que nos dizem exatamente o que é que nós temos que marcar para então depois obtermos a análise da deformidade. E depois surge então um quadro importante que se divide basicamente em 3 pontos. O primeiro é a parte em que nós temos a análise da deformidade, em que nos é dado o ângulo mecânico do fémur, da tíbia e o ângulo mecânico do membro, também o eixo anatómico do fémur e a diferença entre o eixo anatómico e o eixo mecânico. Depois, na segunda parte do quadro, nós temos então a parte da classificação por fenótipos. Temos a classificação funcional, de Michael Leishman, com 25 categorias, a simplificada do professor Bonan, com 9, e depois também temos o CIPAC, que vamos acabar por falar aqui mais, que também está aqui disponível. O que é que acontece quando nós clicamos aqui nestes is de informação? Uma vez mais para a parte educacional, mas também para uma parte mais visual, nós clicando nesta informação, nós vamos ter a tabela resumo dos artigos, que nos vai depois permitir classificar a deformidade do doente, o fenótipo, e perceber depois se estamos fora da safe zone ou já dentro, para nos dar logo uma ideia do que é qual é que é o alinhamento do nosso doente. E o mesmo em relação ao CIPAC. Depois de carregarmos aqui, nós temos uma janela dentro do software que mostra este diagrama que já é conhecido de toda a gente e que permite então ao cirurgião uma classificação do fenótipo. Isto até para motivos de investigação científica acaba por acelerar muito o processo de avaliação destes doentes. Por fim, a última parte da tabela é onde o cirurgião escolhe qual é que é a filosofia de alinhamento com a qual se identifica mais e que acha que terá melhores resultados. Nós aqui temos então a cinemática, a constitucional e a mecânica. E uma vez mais, se nós clicarmos neste tipo de informação, nós vamos ter uma janela que nos vai dizer o que é que significa o alinhamento kinemático, em que é que consiste. Isto é, no fundo, também uma ferramenta de treino e de educação, achamos nós. Depois de escolher então o alinhamento, passamos para esta janela e nesta janela temos então a fase em que vamos escolher quais é que são as nossas ferramentas. Nós podemos usar o instrumental convencional, robô, navegação ou PSI, e depois se usarmos o instrumental convencional nós vamos estar limitados no eixo de válvula, no corte do fémur que temos e que vamos poder utilizar. E nesta fase, aqui nós conseguimos obter praticamente todas as próteses que estão neste momento disponíveis. Como vos disse, nós no nosso caso estamos então a usar o alinhamento constitucional com instrumentação convencional e o nosso limite no instrumental é de 5 a 7 graus porque nós usamos a prótese da Smith&Nephew e portanto temos esta limitação. E depois com um simples clique temos então a prótese com uma ideia do alinhamento do membro com que ficará e temos mais uma vez este quadro que eu acho que é o quadro mais interessante e que acaba por ser um bocadinho o game changer desta situação. Neste quadro, nós vamos ter então uma primeira informação que nos diz, no caso do alinhamento constitucional, que o nosso doente está dentro da safe zone e que, portanto, basta-nos reproduzir esse alinhamento que podemos fazê-lo de forma segura. Aqui, se ele estiver fora da safe zone, portanto, com um ângulo Faro ou valgo exagerado, o software que calcula qual é o ângulo seguro mais próximo e depois faz todos os cálculos em relação a esse novo ângulo formado. Depois, como nós usamos instrumental convencional, ele vai-nos dizer qual é o corte de valgo que nós temos que pôr no fémur e o que é que acontece ao fémur em relação à diferença que há para o fémur nativo. E qual é o target do eixo mecânico do fémur que nós vamos obter. O mesmo para a tíbia e o mesmo para o eixo mecânico final do membro. E depois aqui a parte interessante também é que o software percebe que nós estamos a fazer, neste caso em particular, por exemplo, uma ligeira valgização do membro e o que acontece é que é expectável que do lado de dentro haja alguma tensão da parte dos ligamentos que possa precisar de ser tida em conta para no final termos uma prótese balanceada. E depois aqui o que ele faz também tem em conta qual é o tipo de alinhamento escolhido. Se nós escolhermos o alinhamento cinemático, o objetivo é não fazer libertações de tecidos moles. Se nós no final tivermos uma tensão e a prótese não estiver balanceada por estar apertada, por exemplo, do lado de dentro, a sugestão não vai ser a libertação dos tecidos moles, mas sim um recorte ósseo. No caso, o alinhamento constitucional, se nós estamos já dentro da zona segura, nós não queremos alterar os cortes ósseos, e o mesmo para o mecânico, o que o software vai sugerir são libertações de tecidos moles para fazer esse equilíbrio da prótese. E essa parte também acaba por dar mais confiança e previsibilidade à cirurgia. Isto aqui é basicamente o workflow que nós temos então dentro do software. Já depois da marcação dos pontos, nós temos então esta tabela. A tabela, nós clicando então nestes dias de informação, vamos ter os fenótipos ao lado onde podemos escolher. Depois temos a definição de todos os alinhamentos. Neste caso, nós escolhemos o alinhamento constitucional, que é o que estamos a usar, e com os 5 a 7 graus de válvula de limitação. E pronto, claro que está um bocadinho acelerado, mas nós percebemos que rapidamente, em poucos segundos, conseguimos ter o nosso plano. Depois disso, nós passamos então para o templating. Nós fazemos 2D, depois isto é convertido em 3D. E o que nós temos de resultado final, basicamente, é isto. Este é o nosso plano e depois este aqui é o nosso resultado. Pronto, nós começamos a fazer isto há pouco tempo, desde o início do ano, e não temos um follow-up muito grande. Mas nós também quisemos perceber se fazia algum sentido o que nós estávamos a fazer e se era, de certa forma, reprodutível ou não. O que nós vimos foi que, em relação ao fémur, o fémur-alvo versus o fémur que nós obtivemos, nós estamos com um erro de cerca de 1,6 graus para Faro. E nós achamos que já temos uma ideia porque é que isto acontece, provavelmente por duas coisas. Uma delas é que a conversão do eixo anatómico para o mecânico não é 1 para 1, e isso é um problema matemático que nós estamos a resolver. Depois, aqui ficamos um bocadinho mais surpreendidos porque achamos que na tíbia, que é sempre mais, entre aspas, a olho com o instrumental convencional, nós acharíamos que íamos estar um bocadinho com um desvio maior do que o que temos. E na realidade nós temos um erro inferior a 1 grau para valgo da tíbia. Claro que eles aqui se opõem e nós acabamos com um eixo mecânico final em relação ao nosso alvo com um erro inferior a 1 grau. Claro que aqui depois podemos discutir que podemos estar a alterar ligeiramente a interlinha articular, mas acaba porque nós achamos que não é assim um resultado de todo mau. Em relação ao templating, aí a satisfação é muito maior. Nós temos 95% dos casos que ficam dentro de um tamanho acima ou abaixo, com mais de 50% a ficarem sempre no mesmo tamanho. Isto para nós é ótimo porque dá-nos muito mais fertilidade para a cirurgia. Os próprios instrumentistas, enfermeiros, são agora eles que nos vêm perguntar quais é que são os tamanhos para montarem a mesa, para serem mais ágeis, e acaba por nos tirar algum stress da parte da espera dos componentes e tudo mais. E pronto, basicamente era isto que eu tinha aqui para vos falar. Espero que gere alguma discussão e que tenham gostado.
Está a ouvir? Está a ouvir, sim. Muito obrigado. A discussão fazemos no fim. Vamos pedir agora ao Dr. Peter Savov, que já veio ontem, já começou a trabalhar ontem, teve-me a ajudar numa cirurgia e vai-nos apresentar agora o New Trend in Knee Philosophies.
Okay, thank you very much for the invitation. My name is Peter Sabow. I'm based in Oldenburg, Germany, and I was invited to talk a little bit about the CPEC classification and the new trend in knee morphotypes and knee phenotypes. So in the first talk, we heard a lot of the different alignment philosophies and alignment techniques, and this talk is based on what was mentioned by Mr. De Korte. So in 2019, there were a lot of, maybe it's a little bit higher, right? Yeah. There were a lot of different classification published, for example, from Professor Hirschman in KSSDA, and he identified, for example, 5 different phenotypes of the femur. And as you see it here, you see this is basically the neutral femur with an LDFA of 87 degrees, which was also published from Professor Bellemans. And the horizontal joint line on the femur is very rare. So in almost at least 10% of all cases, the patients had a neutral femur, and in most of the cases, you have a valgus femur. And with introducing the CPEC classification, we are now able to identify or to classify each knee into different 6 or 9 different phenotypes. And I want to explain you how the CPEC classification was built and is calculated and what should be or it could be the clinical relevance to that. So at first, it depends only on 2 parameters, the whole classification. As Ronnie told us in the talk before, we need only the MPTA and the LDFA. And of course, you need a long leg X-ray to measure those 2 parameters. So at first start with the joint line obliquity. So we are calculating the joint line obliquity with a small task when we are editing the MPTA to the LDFA. So the first calculation is MPTA plus LDFA. And then we are looking at the results. If it's almost 100 degree, plus minus 3 degrees, so we have a standard deviation of 3 degrees, then we are talking about a horizontal joint line. Then the joint line is almost parallel to the floor, within 3 degrees, that's important to mention. Is it below 180? So we are talking about oblique joint line with an apex distal. This is the most common one. So our joint line is usually oblique into the medial side of the joint. And on the other hand, we have a joint line obliquity with an apex proximal. And this is, in our opinion, almost, let's say it, academic identification. So it's in the normal way you don't see those kind of morphotypes. They are very, very rare. The next thing is the calculation about the alignment. So Ronnie already told us how to measure it. So we need to make the calculation MPTA minus LDFA. And if these values are 0 within a range of plus minus 2 degrees, we are talking about a neutral alignment. If it's negative, we are talking about the varus alignment, and if it's positive, we are talking about the valgus alignment. But it's important to mention that we are talking here about the arithmetic hip-knee-ankle axis. That's not the same like the weight-bearing axis in a long leg X-ray, because here in this case we are not considering the wear. We are only looking at the bony anatomy of the MPTA and LDFA. And with this calculation, we were able to calculate the alignment which the patient had back in their 20s, for example. So their natural alignment without any wear. So maybe the long leg X-ray shows us a 77 degree of varus with his arthritic knee, but with the arithmetic alignment, he has only, for example, 2 degrees of varus. And this is the alignment we want to reconstruct with our philosophy. So when we combine those 2 parameters, we had this classification boxes with 9 different boxes. So in the upper row, we see all oblique joint line morphotypes with apex distal. And on the third row, we see with the neutral joint line, and then on the third row with the apex proximal joint line. And I can tell you, these ones are quite rare. So in your clinical daily practice, you only see morphotype 1 to 6. And on the different columns, you see the alignment. On the left-hand side, varus, in the middle, the neutral, and on the right-hand side, the valgus alignment. So we are basically focusing on those 6 morphotypes. And when we are watching in the frequency distribution in these morphotypes, that was published in the original study as well, you see that the healthy population, the distribution is almost the same like the arthritic population. And this is due to the fact that we are calculating with the bony references and not taking the wear or the cartilage into account. And there's a nice study is almost published by Professor Bellemans, where he shows that the MPTA and LDFA is not changing during the lifetime. It's almost changing within only 1 degree. So basically, you can rely on the long leg X-rays in the arthritic patient, and you can define that's his natural MPTA and natural LDFA. So the error is only within 1 degree. And back in the days with the mechanical alignment or with the gold standards, we are almost changing every morphotype to type 5. And what happens then? Okay, we already heard the concept of the kinematic alignment, and in the same study, the group performed a comparison between the kinematic and the mechanical alignment in those morphotypes, and they looked into the frequency of necessary balancing steps, soft tissue balancing steps. And they showed that, for example, in CPEC morphotype 1, in 100% with the kinematic alignment, they were totally fine balanced, and only in 15% with the mechanical alignment. So in 85%, they need balancing steps. And you see, even in CPEC type 5, in mechanical alignment, they had to do 40% balancing steps. So with the more personal or individualized alignment, we can reduce soft tissue balancing, and therefore we can reduce maybe the unsatisfied patients. The whole functional alignment with robotic techniques is based on the concept of kinematic alignment, so I can skip through these slides because Ronnie already told us. So we want to balance the anatomy, or we want to balance the knee with respecting the anatomy and maybe do some adjustments in bony cuts. And within our restrictions, sometimes we need to do slight soft tissue releases because for myself, I don't go for 100% kinematic alignment. I have my boundaries within 3 degrees of the bony cuts, and in some rare cases, you have to do some soft tissue releases. So this is almost the same slide Ronnie showed us, with the concept of the kinematic alignment. So the green line is the extension flexion axis of the femur defined by the femur condyle. The medial and the lateral femur condyle define the primary extension flexion axis of the knee, and we want to reconstruct the femur anatomy one-to-one in order to reconstruct the biomechanics of the knee. The tibia is always following the femur. We never start with the tibia. The femur defines the kinematics of the knee. And when we are looking in different morphotypes, so there should be the question, is there the need of different implants? In this specific case, for a symmetric implant and an asymmetric implant. When we are watching at those phenotypes, it's maybe true that the yellow one runs better with the symmetric implant, and the blue one or the green one runs a little bit better with the asymmetric implant. And we analyzed our CPEC distribution with our robotic cases from the year, I guess, 2019 to 2022. And these were all the robotic cases done with 2 different robots, with one asymmetric implant and one with symmetric implant. And I want to show you what happens when you treated those patients with different kind of implants in different CPEC morphotypes. So basically the frequency distribution is almost the same like Professor Bellemans published it. And when we are watching into CPEC type 1, let's start with CPEC type 1, and we have two groups. One group was treated with a symmetric implant, robotic device, and one with the asymmetric implant with another robot. And the red dots were the preoperative CPEC, and the blue dots were the postoperative CPEC. On the left-hand side, you see the distribution with the asymmetric implant, and on the right-hand side with the symmetric implant. And you see up there, you see the numbers, postoperative CPECs in percentage. And we are starting with CPEC type 1. And postoperatively, with the asymmetric implant, we are in 37% again in CPEC type 1. And you see almost the cloud of the dots is almost near to CPEC type 1. With the symmetric one, even though we use the functional alignment with robotic, not conventional, not straight knee, not straight axis, we go for functional alignment with reconstructing the anatomy. With the symmetric implant, we are changing up to 30% to type 5 to neutral alignment, and 33% to type 4, for example, and we are only in 6.9% in the CPEC type 1. So this is without clinical results. At the moment, I can't tell you whether there's a significant clinical influence or not, but this is all, this is the radiological analysis of that. So with the asymmetric implant, you're reconstructing more the CPEC in type 1 compared to an asymmetric one. When we are looking into type 2, it's almost the same. So on the left-hand side with the asymmetric inlay, we are almost quite to the preoperative box. Sometimes we are changing it from type 2 to type 1, right? So we have 30% type 1, even though there were not type 1. This might be a problem too, we do not know. And with the symmetrical one, we are almost changing everyone to type 5. What about the valgus knees? When we are watching into CPEC type 3, we see that we keep the oblique joint line in valgus knees with the asymmetrical one even more with the, compared to the symmetric. With the symmetric, we are always changing to type 5 because this is our safe zone, obviously. So in every valgus knee, no one complains if we're changing the CPEC to type 5 to a straight knee with a horizontal joint line. Everyone is fine with that. But we do not know. Maybe it's better when we keep the oblique joint line, and maybe the patients are doing more well. So we should look into a little bit more in detail in a few years and see what happens in the registry and happens with the clinical scores. But now, interesting-wise, when we are looking into CPEC type 4 with a horizontal joint line, the patients are doing better regarding the radiological results with the symmetric one. So maybe we should consider to have different implants in the box, maybe, I do not know. So with the asymmetrical one, we are changing every time the CPEC from 4 to 1. So we are making from a horizontal joint line to an oblique joint line. And when we are looking into the frequency distribution, we see that almost the 75% of the population has an oblique joint line, so maybe suitable for asymmetric inlay. And that's why our philosophy is, if we're able to, we want to use in those morphotypes the asymmetrical inlay, and in these morphotypes the symmetrical inlay. The morphotype 6 is the most difficult one because there are no soft tissue rules anymore, and that's why always we want to do type 6 into type 5 or maybe type 3. So you need a stable knee in those severe valgus cases like type 6. And when we are talking about the soft tissues are different, although there are differences when we are looking into these different morphotypes. So every knee looks different. Sometimes the radiological results and radiological analysis shows us the same ankles, and every one of you who do total knee arthroplasty knows sometimes the x-ray from patient 1 and patient 2 on the same day with the same x-ray, they feel different in the soft tissues, and everyone is asking itself, why could it happen? So with the robots, you see those differences, and then maybe we can think about it. And we've done a study with the Duke University with Dr. Seiler. And we analyzed, based on the Smith & Nephew database of 1,500 chories worldwide, we analyzed the different soft tissue information prior to pony cuts with a 90-degree planned implant into those different CPECs. And what we see is very interesting. So there are significant difference between the CPEC morphotypes in soft tissues, in the soft tissue information. And when you're looking into type 1, for example, you are always on the medial side tighter than on the lateral side, and you get a little bit more tighter in mid-flexion. But you are always tight even in extension, also in deep flexion. When you're looking into the type 2, so it's still oblique joint line, but the alignment is more or less neutral. You're, even though tighter on the medial side, but you are a little bit more looser compared to CPEC type 1. If we are looking into type 3, the valgus, it's very interesting. So in type 3 valgus, you are in extension, as every one of us known, is looser on the medial side compared to the lateral side. But after mid-flexion, it turns. And on the deep flexion, you are again, like a varus morphotype, tighter on the medial side compared to the lateral side. So type 3 morphotypes are acting in extension like the classical valgus, but in flexion they are acting like a varus. That's very, very interesting. And if we are looking into type 6, for example, the severe valgus with a horizontal joint line, there are no rules anymore. So you are even looser in the medial side compared to the lateral side during the whole range of motion. Those morphotypes are the most difficult ones. Sometimes you need a hinge, sometimes you need a CCK, all that kind of stuff. And with the horizontal joint line, you see that you're in deep flexion on the medial side a little bit looser compared to the lateral side. So there are differences between alignment and oblique joint line in those CPEC morphotypes in soft tissue. Again, this is not based or not, we do not have any clinical data yet to these information. These are brand new. They are currently under review in the Journal of Arthroplasty. So we are looking forward to the future, what happens next. But what is how to achieve now the CPEC in your daily practice? So I think Ronnie has a talk to that later. So I only want to show our metrics we develop, we build, and then you can, and every surgeon can define his personal safe zone, for example. So this is a matrix, really simple, calculated with Excel. So on the x-axis, you see the preoperative LDFA between 80 and 95, because obviously this is the most common. And on the y-axis, you see the MPTA. And in every field here, it's calculated the preoperative CPEC. So you can easily look at this matrix and see, okay, I have an MPTA of 87 and have an LDFA of 88. Okay, I'm in CPEC type 2. Great. So, and then you can define your personal boundaries if you want to keep them in the box or close to the box. And let's start, for example, with the symmetric implant, for example, the legion. These are my personal boundaries. So basically, I am not doing any valgus cut on the femur, on the tibia. So my tibia safe zone is between 90 degree MPTA and 87. So this defines this direction. And I'm not afraid to do 3 degree varus or valgus cut on the femur side. So this defines these box. And now I see, okay, within these morphotypes, I'm totally fine in my radiological safe zone when I'm using a symmetrical implant. And then I can define, or I can decide, okay, now my patient has a CPEC type 3 from here. Now I can define, okay, which type of CPEC I'm looking for example, type 2. Then I see, okay, maybe I should go for a 90-degree cut and maybe 87, 88 degree of the femur. It depends, of course, from patient to patient. Not every time I go for a 3-degree valgus cut. In a valgus case, sometimes only 2. Then I'm aiming for CPEC type 5, and so on, and so on, and so on. So you can define your personal safe zone. The next is the safe zone for the journey. For the journey, the calculation of the safe zone is a little bit different, or a little bit complicated, because of the oblique joint line on the tibia. So you have to calculate it here a little bit different, because you have to subtract the 3 degree of the MPTA, because when you're performing with the journey, you're almost within the 90-degree bony cut. You're reproducing almost, for academic side, a 87 MPTA. That's why we are starting here. That's the only confusing thing on this side regarding the asymmetrical inlay. And you see, with the asymmetrical one, you're totally fine with CPEC type 1 and type 2. And with type 3, you only have to move one step in your radiological safe zone. Yeah, and this is our way to do the functional alignment. And in my next talk, after the lunch session, I will show you how to achieve this with, for example, the CORI system. Thank you very much for attention.
Thank you very much, Peter. Now, ia chamar o Lucas Armada. Nós desafiamos o Emanuel Seiça para tentar, com os nossos arquivos, definir a população portuguesa em termos de CPEC. O Emanuel está fora. O Lucas vai apresentar esse trabalho.
PDF, está em PDF. Não? Porque está em PDF, ele não está a reconhecer. E agora o que a gente faz? Isto está em PDF. Você não tem isto em PowerPoint, não?
Tenho.
Tem aí consigo?
Tenho o e-mail consigo.
Não tem coisa?
Não tenho.
Pá, se calhar pedir ao Dr. João, não sei. Não estou conseguindo, não sei porquê. Ele não está a reconhecer o PDF. Não está. Ele não está a reconhecer.
Não tenho lá dado.
Não está. Hã?
Não tenho lá dado.
Se calhar não tem. Deve ser isso.
Vamos antecipar o coffee break para resolvermos este problema. Pedia-vos para estarem aqui. Ora, o vinda do coffee break era às 11h30. Às 11h20. Está bem? Às 11h20 retomávamos.
so I can take a look around at what you see. I can see from where I am you're on an adventure in a place can't be captured in words. So show me colors, colors I need, pictures this time. Show me food and sights and sounds. I wanna know what you find. I want colors, colors, please. Show me life ain't black and white. Let me see you on the other side of the line. Show me colors.
Bom, vamos começar. Já está pronta a apresentação. Para ver se mantemos isto mais ou menos na hora.
Bom dia, o meu nome é Lucas Armada, eu sou interno do segundo ano do Hospital Beatriz Ângelo. Hoje venho em representação do principal autor do nosso estudo, o Emanuel Curtson Seissa, que infelizmente não pôde estar presente. O título do nosso estudo é Characterization of the Knee Joint Phenotype in the Portuguese Population. Quero agradecer especialmente ao Dr. João Paulo pela oportunidade de podermos ter feito este estudo. É um estudo que ainda não foi publicado. Ora bem, como vocês sabem, a estratégia, o gold standard das próteses do joelho tem sido o alinhamento mecânico, portanto, a opção pelo alinhamento neutro, pelo alinhamento, pela obliquidade da linha articular neutra. Apesar disso, nós sabemos que 20% dos doentes permanecem insatisfeitos após a cirurgia e, por isso, temos que pensar na anatomia individual dos doentes. Ou seja, será que, ao estarmos, portanto, a utilizar um standard para todos os doentes, podemos estar a explicar a razão por trás destes 20% de doentes que continuam insatisfeitos? Nós, no estudo, utilizámos este sistema que o Dr. Peter apresentou, de Coronal Plane Alignment of the Knee, e, portanto, pensando que diferentes populações pudessem ter diferentes fenótipos, nós tentámos utilizar esse sistema e caracterizar a morfologia do joelho da população portuguesa. Secundariamente, tentámos investigar a relação entre o Coronal Plane Alignment of the Knee, CPAC, e a osteoartrose, portanto, das articulações adjacentes, nomeadamente da anca e do tornozelo, e ainda fomos tentar fazer um cálculo do alinhamento pré-doença, do alinhamento coronal pré-doença, e tentar compará-lo com o fenótipo atual e com o membro contralateral, com o joelho contralateral. E basicamente fomos analisar todos os raios-x extralongo realizados entre janeiro de 2016 e maio de 2023, realizados no Hospital Particular do Algarve. Após termos excluído alguns doentes, ficámos com um total de 624 joelhos, eu esqueci-me de pôr ali, uns 624 joelhos de 320 doentes, sendo que os critérios de exclusão foram uma artroplastia ipsilateral, fraturas dos ossos longos e ipsilaterais, uma dismetria dos membros inferiores, deformidades intraarticulares não atribuíveis à osteoartrose, sequelas de osteomielite, doença neurológica, eventos vasculares major. Além disso, excluímos ainda os doentes que tinham um posicionamento radiográfico inapropriado e depois de calculado o HKA aritmético, se fosse abaixo de menos 15 graus ou acima de 15 graus, também excluiríamos estes doentes. O nosso estudo tem três coortes. Uma coorte de joelhos com artrose, portanto, aqui nós vamos falar relativamente a uma população de joelhos e numa população de doentes. Portanto, a primeira coorte tem a ver com os joelhos, portanto, artrósicos, portanto, joelhos com sintomas cujo o Kellgren-Lawrence seria 1, 2, 3 ou 4. Isto representa um total de 120 joelhos com uma idade média ali nos 60 anos. Depois tínhamos joelhos assintomáticos de adultos saudáveis, que representam 296 joelhos, com uma idade média de 41 anos. E, por último, uma coorte de doentes pediátricos, com 208 joelhos assintomáticos, com uma idade média de 14 anos. E o que é que fizemos? Fomos pegar em 5 parâmetros, medimos-los, estes que estão aqui, já foram falados, e calculámos 2 parâmetros que também já foram falados. O grau de osteoartrose foi baseado na escala de Kellgren-Lawrence e fomos analisar a presença de osteoartrose nas articulações adjacentes. Portanto, eu não vou voltar a referir isto, o Dr. Peter explicou isto muito bem. Pronto, aqui é uma ilustração, só uma ilustração nossa, um bocadinho diferente daquele que apresentou. Pronto, apresentam-se os 9 morfotipos associados à classificação. Fomos tentar, portanto, depois calcular o alinhamento coronal pré-doença e utilizámos uma fórmula que foi descrita por William Collin, que usa o grau de Kellgren-Lawrence, a classificação e estes 4 parâmetros. No entanto, esta fórmula só se aplica tendo em conta a frequência, portanto, sendo os grupos mais frequentes, esta fórmula só é válida, portanto, eles só a validaram para o fenótipo 1 e 2 do CEPAC. E os resultados? Relativamente ao MPTA e ao LDFA, portanto, como esperado, o grupo da artrose seria aquele que teria o MPTA médio mais baixo e o LDFA médio mais alto. No entanto, as diferenças que encontramos não foram estatisticamente significativas. Por outro lado, relativamente ao HKA aritmético, já temos diferenças estatisticamente significativas, sendo que no grupo da artrose temos uma média de um HKA aritmético de menos 1,7 graus. Sendo que o alinhamento mais comum, como seria de esperar para a população artrose, portanto, para os joelhos artrósicos, seria o VARS, portanto, e por outro lado, relativamente à população dos adultos saudáveis e pediátrica, o alinhamento mais comum seria neutro. Relativamente aqui à distribuição do fenótipo, na população da artrose, os fenótipos mais comuns foi inicial, portanto, primeiro o 1 e depois o 2. Podemos encontrar uma associação entre o grau de Kellgren-Lawrence e o HKA aritmético, ou seja, quanto maior o HKA aritmético, maior seria o grau de Kellgren-Lawrence. Ou seja, para um grau 0, teríamos uma média de varos ali nos 2,7 e uma média de valgos ali nos 2,8 graus, enquanto que num Kellgren-Lawrence de grau 4 teríamos uma média de varos nos 9,7 graus e uma média de valgos nos 8,7 graus. Relativamente à obliquidade da linha articular, já não conseguimos encontrar diferenças, portanto, estatisticamente significativas. Falando da população saudável, portanto, o fenótipo mais comum, o morfotipo mais comum seria o 2 e a seguir o 1. E relativamente à população pediátrica, o 2 e a seguir o 5. Relativamente aqui aos géneros, fomos tentar ver se haviam diferenças entre géneros. E o que podemos verificar na população da artrose foi que o género, portanto, mais comum, o morfotipo mais comum seria o 1 e para as mulheres o morfotipo mais comum seria o 2. Relativamente à população saudável, o morfotipo mais comum em ambos os géneros seria o 2. Aqui, sim, encontramos diferenças entre os géneros estatisticamente significativas e na população pediátrica, apesar dos morfotipos mais comuns portanto, serem como a população saudável, o morfotipo mais comum ser o 2, as diferenças não foram estatisticamente significativas entre os géneros. Fomos ainda, portanto, olhar para a osteoartrose das articulações adjacentes e aquilo que vimos foi que na população da artrose, portanto, a prevalência de artrose nas articulações adjacentes era maior. Não conseguimos encontrar diferenças estatisticamente significativas relativamente aos diferentes fenotipos morfotipos do CEPAC e da osteoartrose adjacente. Relativamente, portanto, ao cálculo do alinhamento coronal pré-doença, o que é que nós verificámos? Foi que, quanto maior o Kellgren-Lawrence, maior seria a diferença entre o alinhamento coronal pré-doença e o alinhamento HKA aritmético inicial. Pronto. E depois, portanto, eu tinha mencionado, portanto, que a fórmula só se aplicava, portanto, ao morfotipo 1 e morfotipo 2, por isso é que nós só apresentamos estes morfotipos aqui. E relativamente ao morfotipo 1, é destacar que 16 dos joelhos, 64% dos joelhos, mudaram de um alinhamento varos para um alinhamento neutro. E apenas 3 destes tinham realmente correspondência com o contralateral. Portanto, 3 destes, após o alinhamento pré-doença obtido, é que teriam correspondência com o contralateral. Estas figuras mostram, portanto, que a distribuição do HKA, portanto, calculado pré-doença, teria uma distribuição, portanto, similar à dos adultos saudáveis. Ora, muito bem, a população portuguesa, então, como vimos, é constituída sobretudo por joelhos neutros nos indivíduos saudáveis e pediátricos e por joelhos varos em indivíduos, portanto, em joelhos com artrose. Apesar de tudo, ambos, como o Dr. Peter disse, têm portanto, a predominância da obliquidade da linha articular com o ápex distal. Como em outros estudos, portanto, os nossos resultados mostraram uma tendência para um alinhamento em valgos ou neutro nas mulheres e o alinhamento neutro ou varos nos homens. Não encontramos relação entre o Kellgren-Lawrence e o CIPAC, encontramos apenas com o HKA aritmético. Portanto, sendo que os dois, portanto, aumentam um com o outro. Relativamente, portanto, à predição do alinhamento constitucional, como podemos ver pelas figuras, comparando com os adultos saudáveis, pode estar de acordo com o alinhamento pré-doença. No entanto, o que vimos foi que, portanto, nem todos os doentes dentro do CEPAC1, do morfotipo 1, mudaram de alinhamento. Ou seja, quando nós aplicamos, portanto, um alinhamento neutro e uma obliquidade da linha articular neutra, será que estamos a fazer bem? Portanto, provavelmente não, sendo que nem toda a gente, portanto, nem todos os joelhos teriam alinhamento neutro de base e, portanto, é preciso tentar ir investigar, portanto, o alinhamento de base. Relativamente portanto, a esta predição, como vimos, apenas 3 dos 16 joelhos tinham realmente, portanto, uma correspondência com o alinhamento do joelho contralateral, por isso, provavelmente, devemos parar de predizer com base no joelho contralateral. Mais uma vez, portanto, o fenotipo não teve associação com a prevalência da osteoartrose nas articulações adjacentes. Limitações relativamente ao nosso estudo poderão ter a ver com erros de medição radiológica por deformidades rotacionais do fémur distal que não conseguimos detectar pelas radiografias. E, tendo em conta que o CEPAC apenas considera o alinhamento coronal, provavelmente não estamos, portanto, a considerar todos os fatores que entram, portanto, que têm influência no balanço do joelho. E por isso, provavelmente, serão necessários mais estudos em que se faça um alinhamento tridimensional. Portanto, a destacar, então, a variabilidade da morfologia, portanto, dos joelhos dentro das populações, o cálculo do alinhamento pré-doença, juntamente com a classificação do CEPAC, poderão ser úteis na prática clínica corrente e futura e talvez conseguindo, portanto, corrigir ou talvez conseguindo melhorar os resultados relativamente àqueles 20% de doentes que ficam insatisfeitos após a artroplastia total do joelho. E, portanto, é aí que nós achamos, portanto, que a cirurgia robótica poderá ter um papel importante. Obrigado.
Obrigado pela apresentação. Este trabalho já está proposto para... Qual é a revista que...
Portanto,
é parte Arthroplasty, não é?
Sim.
Obrigado. Vamos passar então a seguir a Maria Miguel. Maria Miguel nós temos uma base de dados bastante extensa dos nossos próteses do joelho e fomos lá buscar a correlação tentar encontrar alguma correlação clínica entre o CEPAC pós-operatório e também a migração do CEPAC pré para o pós-operatório.
Olá, muito bom dia a todos. Como o Dr. João Paulo já disse, então vamos continuar e não perder muito tempo, já estamos um bocadinho atrasados. Não vou continuar a falar aqui muito na classificação que já falamos, mas eu vou manter sempre a imagem porque sei que esta classificação não é familiar para toda a gente e, portanto, assim mantemos sempre ali a ideia do que estamos a falar. Como já foi dito, o CIPAC considera 9 fenotipos, essencialmente com base no alinhamento do joelho e na obliquidade da linha articular. O objetivo com este trabalho é, então, perceber de que forma a classificação final, após a artroplastia total do joelho, CIPAC, vai ter influência no outcome e, como segundo objetivo, perceber se a manutenção do fenótipo pré-operatório, se isso vai trazer uma vantagem funcional ou não. Para isso, fomos avaliar os nossos doentes submetidos à artroplastia total do joelho. Selecionamos os doentes em que era possível ter acesso à radiografia extralongo dos membros inferiores pré- e pós-operatoriamente. Uma vez que a avaliação pré-operatória para o sistema Visionaire obriga a realização do extralongo e os registra informaticamente, a nossa amostra é toda feita pela instrumentação específica para o doente PSI. Temos então uma amostra de 197 doentes, cuja cirurgia foi realizada entre fevereiro de 2015 e maio de 2023. Temos 66% de mulheres, uma idade média de 71 anos e um índice de massa corporal médio de 29,3, sem diferenças relativamente significativas entre o lado direito ou esquerdo. Fomos avaliar, então, nestas radiografias extralongas, o HKA e a obliquidade da linha articular. Os nossos doentes, de uma maneira rotineira, são sempre avaliados pré-operatoriamente à data de alta, aos 30 dias e aos 90 dias pós-operatórios. Depois, a seguir, vamos já ver, em relação ao score do OMAC, que avalia a dor, a rigidez e a funcionalidade nas atividades da vida diária, o perímetro de marcha de 6 minutos, a flexão, a escala analógica da dor e a satisfação. E então, com base nestes critérios, fomos ver os resultados. Vemos então aqui a distribuição dos doentes pelos diferentes tipos de CPAC e verificamos que pré-operatoriamente a maioria dos doentes tem um joelho varo com um ápex distal também, como já foi dito. O mais raro são os grupos, como o Pedro já tinha dito, os grupos 7, 8 e 9, que, portanto, também estão aqui apenas em 3% dos casos. Pós-operatoriamente, o que verificamos é que mais de metade dos doentes têm um alinhamento coronal neutro e uma obliquidade da linha articular também neutra, o que faz sentido uma vez que utilizamos um alinhamento mecânico neutro. Portanto, esse é o nosso objetivo. Mas o que verificamos, e que é curioso, é que mesmo com esse objetivo do alinhamento neutro, ainda 47% dos doentes caem fora desse objetivo, ou seja, em 47% dos doentes nós não conseguimos esse alinhamento neutro. Será que isto vai ter alguma implicação depois futura em termos de funcionais? É o que vamos ver agora de seguida. Aproveito aqui ainda também para mostrar lado a lado, portanto, as classificações pré- e pós-operatoriamente e, de facto, há esta tendência de os vários pré-operatoriamente e depois pós-operatoriamente o eixo mais próximo do alinhamento neutro. No entanto, chamo também a atenção que o alinhamento coronal neutro com uma linha articular neutra só foi atingido em 37% dos doentes. Portanto, mesmo assim, o tipo 5, que era o nosso objetivo, só 37% dos doentes é que o atingiram. Aproveitando o trabalho também já realizado pelo Emanuel Seiza e apresentado pelo Lucas, vemos de facto que a nossa amostra coincide com a amostra da população portuguesa artrítica. Portanto, tem a mesma tendência, apesar de, claro, os números são diferentes. Fomos então avaliar os resultados e aqui avaliamos os ganhos, ou seja, fomos comparar os 90 dias com o pré-operatoriamente. De uma maneira geral, para a amostra, verificamos que existe ganhos em todas as variáveis, uma grande satisfação e um aumento dos scores. Quando fomos avaliar individualmente para cada tipo de classificação de CPAC, portanto, para cada um dos morfotipos, não houve diferenças estatisticamente significativas entre os grupos. Fomos então perceber quais seriam as migrações mais frequentes, ou seja, qual era o tipo de CPAC pré-operatoriamente e qual era o tipo para onde eles migravam mais frequentemente pós-operatoriamente. E também, mais uma vez, como nós temos como objetivo o alinhamento neutro, verificamos que a maioria migra para o tipo 5, que era o expectável. Verificamos ainda que apenas 20% mantêm o mesmo fenótipo, ou seja, os que eram tipo 1 mantiveram tipo 1, tipo 2, que mantiveram o mesmo fenótipo, só 20% é que mantêm este mesmo tipo. E a maioria são os do grupo 5 do alinhamento neutro. Tentando responder ao segundo objetivo, portanto, será que a mudança de fenótipo ou o restauro do fenótipo pré-operatoriamente vai ter implicação clínica? Nós fomos agrupar os joelhos varos, os joelhos neutros e os joelhos valgos. Portanto, associamos aqui as classificações para ser mais fácil de analisarmos. E o que verificamos foi que existe diferença estatisticamente significativa para o OMAC e para a escala analógica da dor quando migram para o tipo neutro. Ou seja, o que parece ser mais vantajoso é, de facto, aqui os tipos de alinhamento coronal neutro. Já comparando os doentes que mudaram de morfotipo, ou seja, que passaram de valgo para varo ou de varo para neutro, os que mantêm o mesmo morfotipo parecem ter menos dor, maior desempenho no perímetro de marcha e no score do OMAC. No entanto, aqui nós não conseguimos ter, portanto, são diferenças, descritivamente vemos essa diferença, mas estatisticamente não há, essa diferença não é significativa. Da mesma forma, fomos avaliar aqui em relação à obliquidade da linha articular. E aqui agrupamos em ápex distal neutro e ápex proximal. E aqui não verificamos qualquer diferença estatisticamente significativa. Tal como já foi dito, pré-operatoriamente o ápex é essencialmente distal e pós-operatoriamente a maioria termina com ápex neutro, que também é o nosso objetivo. E em termos de mudança aqui de morfotipo, 40% mantém a mesma inclinação da linha articular, mas também não há qualquer diferença, mantendo ou com diferença no pós-operatório para o fenótipo. E então, como discussão, bem aqui há alguns pontos que depois podemos falar mais tarde, mas pronto, nós percebemos que o CIPAC nos dá melhor compreensão em relação a estes fenótipos, em relação ao alinhamento, mas o que nós questionamos é que se apenas 37% dos doentes em que nós fomos à procura de atingir um alinhamento neutro, portanto só em 37% é que conseguimos esse objetivo, será que ao estarmos à procura de um alinhamento sistemático que cai mais fora do alinhamento neutro, vamos ter mais outliers? Isso é algo que temos que ter em conta. Afirmamos também que, pronto, com base nos nossos estudos, que a migração do fenótipo do joelho para neutro melhora os scores de OMAC e de EVA, e também, por sua vez, restaurando o fenótipo pré-operatório, também temos uma melhoria em termos de OMAC e de dor. Portanto, há aqui duas coisas a ter em consideração. Como limitações, podemos apontar o facto de que utilizamos, e como o Peter já falou, são implantes diferentes, assimétricos e simétricos. Temos alguns doentes operados com o implante Legion e outros com Journey BCS, que poderá ser algo que influencia os resultados. O facto de serem todos PSI, não temos nenhum grupo de controle, não é? E apesar de nós fazemos a avaliação aos 90 dias, porque sabemos que é quando começa a haver um platô em termos funcionais, mas poderá ser interessante também de futuro avaliar mais, com maior seguimento de follow-up. Portanto, concluo então dizendo que, de facto, percebemos que o alinhamento mecânico altera o morfotipo na maioria dos doentes pré-operatórios e parece que as alterações deste morfotipo têm implicações quer em termos de score de OMAC, como em termos de dor. Quanto mais pequenas são estas diferenças, parece que menos implicação vão ter para o nosso doente e, portanto, o nosso doente vai ficar mais satisfeito com o resultado. Muito obrigada.
Obrigado, Maria Miguel. Estes dados foram avaliados um bocadinho ainda superficialmente e à pressa, mas temos que os aprofundar um pouco mais. I call again Ronnie, please, for your presentation.
Thank you. We've been talking CPAC now since almost 2 years, and for a lot of people it makes sense because it's a rather easy way to define how the patient was before arthrosis and try to bring that back. The question that we have now very often is, okay, but how are we going to implement that into our daily business? And so, as a company, we made several protocols, and as been said also from previous speakers, we have 2 implants that we have to look at. So we have a symmetrical one, and we have an asymmetrical one. So in the asymmetrical, you see clearly the difference. The joint line is built in, so there's 3-degree varus in the insert, while the cut is perpendicular. And on the femur, it's just the opposite. We have the cut perpendicular, but you have 3-degree valgus in the femoral component. So this is what you have to calculate, and as Dr. Savov was saying, can make it a little bit complicated. And we can perform that in different ways. You can use conventional instruments, or you can use new technology. So that means you can go for patient-made cutting blocks, or you can go for robotics. So that means that we made, in fact, 6 different protocols, depending what you prefer, which implant and which technique, how you're going to build that in. So we'll try to go over rather quickly. So if we start with the conventional instruments, then in fact we made a specific protocol for each of these groups that you see here. So for the 9 groups, we made a protocol. And I will give you 2 examples just to show you how we calculate it, and then I will give you the overview of that protocol. So this is a patient coming in. So you see here, 91. So if you look at the X-ray, you see immediately this is a varus with an apex distal. You can see it on the picture. So this is a patient sitting in group 1. If you're not sure, then you can calculate, and we have seen how to do that. So to look at the overall alignment, MPTA minus LDFA, so this gives you 83 minus 91 is minus 8. So that means it's bigger than minus 2, so it's a varus. Joint line obliquity, MPTA plus LDFA, so this is 174. It's lower than 177, so that means this is a varus with an apex distal. So to keep that patient in that type 1, we need to, if you do the calculation, be more than minus 2, and for the MPTA plus LDFA, it has to be lower than 177. So what is the strategy that we're going to follow here? Well, we're going to restore MPTA to 87 and the LDFA to 89. That's what we're going to restore to keep the patient in CPEC group number 1. So where is this coming from? Well, I've showed you already that study from Johan Bellemans where he looked at constitutional alignment. He also looked at not only the overall alignment, but also at several parameters like MPTA and LDFA. So this is where the results are coming from. So if you want to restore MPTA 87 and LDFA 89, and you're going to use MPTA 87, it means that with the symmetrical implant, you're going to cut the tibia in 3-degree varus. And you're going to use a symmetrical insert on it. So that's. If you look at your femoral cut, LDFA 89, that means 1 degree valgus. So how are you going to calculate that, or how are you going to work with it? Well, you know you measure the normal angle, mechanical axis, anatomical axis. Let's say this is 6 degrees. So instead of cutting 6 degrees when you're pushing, you need to cut, you're going to add 1 degree more. So you're going to add 1 degree, that means 7 degrees. That's going to be 1 degree of valgus in your femur. So if you do that, and then you make your calculation, you're spot on to keep that patient in type number 1. That's a tool. Due to time, but if people want to know how, okay. So this is a tool to look at that LDFA, but due to time, I will skip that. If people want to know more about it, I'm more than happy to explain it on the break. So what about keeping that patient in type number 1, but doing it with an asymmetrical implant? So as we said already, you have 3-degree varus built in the insert and 3-degree valgus in the femoral component. So you have to calculate that. So it means if you want to have an MPTA of 87, you're going to cut the tibia at 90 degree, and the 3-degree varus are going to lead automatically to the MPTA of 87, 3-degree varus. Okay? On the femur, you want to have an LDFA of 89. That's a little bit more complicated. Yeah? So you want to have 1 degree valgus in the femur. In the implant, you have already 3 degree valgus in the femur. So you're going to cut 2 degree varus to compensate for that 3 degree in the femur, that you end up with 1 degree valgus. Yeah? Is that clear? So this is how you're going to look at case by case and how you're going to end up with the goals that you put forward before. So depending if you use a symmetrical implant or an asymmetrical implant. And if you do then the calculation, then you end up and you are fixed in group number 1. Just a second example. I'm not going to go over all of them, just group number 2, that you know how we are calculating. So patient coming in, straight legs, apex distal. So this is a type 2. Again, if you're not sure and you want to calculate, okay. For the alignment, MPTA minus LDFA 0, so that's clearly a neutral. MPTA plus LDFA 174, so this is lower than 177, so this is an apex distal, this is a type 2. So what are we going to aim for to keep that patient in type 2? Well, we're going to aim for an MPTA of 87 and an LDFA also of 87. This is what we're going to do as our cuts. Again, this is coming from that study from Bellamont. These values are coming from there. So how are we going to do that? If you have a symmetrical implant that you see over here, MPTA 87 means 3-degree varus on the tibia. We have a symmetrical implant, so it's not changing. It stays the same. An LDFA of 87, that means 3-degree valgus on the femur. Well, it means that you're going to cut, you're going to measure again. Let's say the example was 6 degree. You're going to add 3 degree on that, and you're going to cut 9 degree instead of 6. Yeah? So that's going to leave 3 degree of valgus in your femur. And then you reach the goals that you put before. So in other words, what you see over here, this is anatomical alignment that you're doing. Yeah? 3 degree varus on the femur, 9 degree valgus on the tibia, and 9 degree valgus on the femur. If you have an asymmetrical implant over here, remember the 3 degree varus is built in your insert, 3 degree valgus is built in your femur. Well, that makes it in fact very easy for a type number 2, because you want to have an MPTA of 87. So that means you're going to cut the tibia 90 degree, and you end up automatically, because of that insert, with an MPTA of 87. On the femoral side, LDFA of 87, just the same. You're going to cut perpendicular to the mechanical axis, so 90 degree, and the 3 degree valgus in your implant are going to give you automatically that 3 degree to have an LDFA of 87. So this is in fact mechanical alignment that you're going to perform with an asymmetrical implant. So this is just to show you how we are dealing and how we did that step by step, CPEC group by CPEC group. And these are the values which are coming from that study from Professor Bellamont. So this is the type of CPEC that you have. This is if you're going to use a symmetrical implant, and this is if you're going to use an asymmetrical implant. So you see, for some of them it's the same values, for others it's a little bit changed, and this is for the rest of the groups. And then you can put everything together into a table. It looks complicated, but it's not really. So what you see here, this is the table when you're working with a symmetrical implant, looking at the femur. These are the different types that you see over here, and this is what we explained. So this is what you're going to aim for, the values of the LDFA, and this is how we do that. So group type number 1 on the femur, I showed you, you're going to add 1 degree valgus, so plus 1. Group number 2, you're going to add 3 degree valgus on the measurement that you do, so plus 3. So in fact you only have to look at this one, and you can put that immediately on the classification over here. So this is what you're going to do on the femoral side if you're using a symmetrical implant. Tibia, for a symmetrical implant, different CPEC groups, this is what we're going to aim for. So 3 degree varus, 3 degree varus, 1 degree varus, 3 degree varus. So this is the most important table for the tibia. Again, you can put it on the classification, and then if you put everything together, this is in fact the protocol if you want to keep CPEC and if you want to work with conventional instruments. So in orange, this is what you do on the femoral side. In green, this is what you do on the tibial side. Same for the journey or for the asymmetrical implant, but here it's a little bit different because, as I explained, the resection LDFA is different as the implant LDFA. So you have that 3 degree varus which is built in over there. So type 1, we reduced 2 degrees. Type 2, we cut neutral. So again, this is the same, the most important column that you have. So you can put it on the table here. This is what we do on the femoral side if you're going to use an asymmetrical implant. And this is what you're going to do on the tibial side if you're going to use an asymmetrical implant. Yeah. And you can put it again on that table, and then you see this is the protocol if you want to keep CPEC and if you want to work with conventional instruments. Nice to see, if you have this implant available, these are the cuts that you do on the tibial side. Okay? So I think it's very easy to understand, and this is much more easier to go for a perpendicular cut on your tibia than aiming for 1 or 2 or 3 degree with conventional instruments. So I think this is the big advantage if you look at that system. So if you put them together, this is what you get. So this is for conventional instruments. What about patient med cutting blocks? So for those of you who know patient med cutting blocks, then you know that you get a planning back from the engineer. So this is the planning, standard planning that you get back with our system. Well, if you want to include CPAC, you can do that now. And then they're going to add this part of information in here. So what you see here is preoperative. They will tell you MPTA, LDFA, which CPAC type this patient is before the surgery. You can measure, and you can see it here on the pictures, MPTA and LDFA that they measure. And then this is what you want to do. So you can say, I have my own boundaries. This is what I want to achieve. Or you can go back to the values from Professor Bellemont's. And depending on the CPAC type, this is what they're going to restore. And you're going to find that back in the planning. So they're going for an MPTA of 87. So it means he's using journey. It means you cut perpendicular on the tibia. 3 degrees are coming from the insert. An LDFA of 90. So it means on the femoral side, they're going to add 3 degree varus to compensate for the 3 degree valgus in the implant, and you end up with an LDFA of 90. Also nice to see is that you see where that patient is sitting here in group number 4, preoperative, and if you follow the guidelines over here, you stay very nice in group number 4. So this is if you're going to use Visionaire or patient med cutting blocks. What about robotics? Well, with robotics, you're going to look preoperative, which kind of type is that patient, in which group is he sitting, and then we see that people are working in different ways. So some people, they start with restoring MPTA, LDFA, the values from Bellemont's. They want to restore these values, and then they continue. Other people, they want to restore the current MPTA and LDFA that that patient had at that moment. So in other words, this is in fact doing pure kinematic alignment that they are doing. And another group of people, they like to do shape matching. So I'm coming back to that a little bit later into detail. But once they started from their different starting point, then they're going to work all in the same way. It means they will get the planning from the system. They're going to look at alignment, joint line, height, size, how much bone they're going to cut away. And then also they're going to look at the ligament balancing, because that's the advantage, of course, that you can check your ligament balancing before you do any cut. If the ligament balancing is fine, they're going to perform the surgery. If the ligament balancing is not fine, as we said before, functional alignment, they can correct the planning to make that the ligament balancing is correct, staying within the boundaries that they have before. Can look a little bit complicated, just to show you some examples. So this is if they want to follow these values that you see over here from Professor Bellemont's. Yeah. So this is an example. If you have a patient coming in with type number 4, so what we're going to try to restore is an MPTA to 87 and an LDFA to 90 if you're going to use a symmetrical implant. So this is the starting page that you get from the planning. They always start from mechanical alignment, and then it's up to you to go from that position. So you see here, this is a patient coming from 9 degree varus, I think, and they bring him back to 0, mechanical aligned. So, but you want to have an MPTA of 87 and an LDFA of 90. So very easy. In your planning, you can give 3 degree varus on the tibia, neutral on the femur. You end up with 3 degree varus. You check your ligament balancing that you see over here. If this is fine, you can continue with the surgery. If it's not fine, you can go back and then you can adjust position, height, or whatever you want to balance the knee in a better way. This is another example, or just the same patient, but then coming in and you're going to do an asymmetrical implant. So the same starting position that you have over here, but you want to have an MPTA of 87. Remember, 3 degree in there, so it means you're going to cut 90 degree, and the 3 degree is coming from the implant. So 0, cut over here. Femur, just the opposite. You want to have an LDFA of 90, so you're going to put that in 3 degree varus to compensate for the 3 degree valgus in the implant, and you end up with 90. You look at your ligament balancing. If this is fine, you can perform the surgery. If not, you have to go back and change the planning until it's fine. The other option I said is when people want to restore MPTA and LDFA like it is at that moment. So this is an example. If you look at it, this is the same patient, type 4. So if you look, it's an MPTA of 85, I think, and an LDFA of 94. So 9 degree. So that means this is what you're really going to bring back. So you have 5 degree of varus in the tibia, 4 degree of varus in the femoral component, and you end up with 9 degree. So this is, as I mentioned before, pure kinematic alignment. So the question is here, if you believe in that, how far are you going to go and where are your boundaries? I'm just saying it's an option that some people are using. The other one is shape matching, and then people can refer to the healthy side if they do a case and build up from the healthy side, or you can go from the medial side, or you can have other references, but Dr. Savov is going to explain after lunch how they're doing it, and they are in shape matching way of working, so he will explain that more into detail. So, what we learned in the meantime for looking at all these different protocols is that if you see how we are working with conventional instruments and with the visionary blocks or with robotics, there is a difference. So here, you're going to define what you're going to aim for. Most of the time, it's the values that we got from the study from Bellamons with conventional instruments and with visionary blocks. You do the surgery, and then when the cuts are made, you're going to do a balancing. You can do that with spacer's block or with your trowel component that you're going to put in. If it's not well balanced, at that moment, you have to do some releases to balance that knee. And then you end up the surgery. And that's different. That part is different if you look at robotics. Because here, depending on what starting point you have, you will have a planning. You can look at it. And if you see that you have your planning, but your ligament balancing is not ideal, you're not going to say at that moment, I'm going to do these cuts, and then I will do a ligament balancing, a release. You're not going to do that. You're going to change your planning in that way that you know that you don't have to do any releases. And by doing that, just changing 1 degree, you see that often you're going to change from CPAC group. So this is something that we learned. So this is why in the beginning we're starting to say, keep them into the box. And this is, Dr. Savov mentioned it already, we are changing this now as keep them close to the box. Because this is how, by changing 1 degree, how quick you can change from one group to the other group. So if you look at it, this is the experience that we have. And this is also something that we saw if you have a patient sitting in group number 3, 6, or 9. So in other words, if this is a valgus patient, then most of the people, they're not going to put him back.
Hello,
in that
good morning. I
valgus.
am
If you have a patient coming in 6 or 7 degree valgus, then most of the people are going to bring him back to neutral or 1, maximum 2 degree of valgus. So not everybody is going to keep him in that 6 or 7 degree valgus. So that means automatically that you're going to change from group 3 to 2, or 6 to 5, or 9 to 8, because the boundaries here are plus minus 2. So you can bring him in 1 degree valgus, he's still in valgus, but you're going to change him from this column to this column because of the boundaries. Another thing that we saw is when you're using an asymmetrical implant and you're playing in this row over here, Dr. Savov mentioned it already, then you see that they can move to 1, 2, 3, just because the insert has that 3 degree varus built in. So we looked at that with a surgeon in Belgium, and this is what he found, a little bit like you did the study here in Portugal. So pre-op, the CPAC group, post-op, the CPAC group, so the ones in green, they are the ones that stay in the same group. The ones in red, they are the ones that changed from one group to another group. He's using robotics, and he's using journey. So if you look at it, we saw that in fact 60% of the cases is changing from one group to another group. And if you look more into detail on that group, then you see half of it is changing because of the alignment. And if you look at all of these cases that you see over here, then in most of the cases they are changing from type 3, that means valgus, to type 2. That's the biggest change that you see, and this is what I was saying. Nobody, or not a lot of people, will keep that patient in 6 degree of valgus. They're going to reduce it to neutral or 1 degree, and this is what you see in here. Some people don't like to have 5 degree varus. Again, this is depending on the boundaries, and they also bring it back to 3 or 2 degrees, but that's also changing then from one group to another group. So this is an example. I will not go into too much detail due to the time, but this was a patient with 7-degree valgus that they had preoperative, and this is the planning that they did on that patient to bring him back to 1-degree valgus. So in other words, that patient is changed from group number 3 to group number 2. The group that you see over here, this is the group that changed because of the joint line orientation. The guy is using an asymmetrical implant. So automatically, in a lot of cases, from 5, 6, you go to 2 and 3. So this is an example here, very standard, but he brought him from 5, neutral, to group number 2. And then you have a small group which has a combination of both together. So the question is, what is happening if you're going to bring patients from group 4, 5, 6 into group 1, 2, 3? Is that a problem, especially if you're going to look at that implant? Dr. Salvov mentioned it already. If you look at the biggest groups that we have over here, so this is around almost 80% in group 1, 2, and 3 sitting over there. So this is ideal for that implant, an asymmetrical implant. If you look at 5 and 6, that's only 10%, and so this might be more ideal for a symmetrical implant. But what is going to happen if you're going to use an asymmetrical also for these cases? Is this going to have consequences on the prompts of these patients? So we're looking at that now for the moment, and it's based on a big study that has been published already. So this is more than 1,000 cases that have been published. The goal on these patients was to perform mechanical alignment. And so when they were looking back, they saw that preoperative, the biggest group was 1. Postoperative, the biggest group was group number 5. Logical, because they performed mechanical alignment. Yeah? But very interesting, only 18% stayed in the same CPAC group. They were not aware about CPAC when they were doing the surgery. But interesting is if you look at the prompts, so if you look at the prompts of all these patients, then you see that only one change had influence on the outcome of the prompts. And this is when you're going to change patients here from an apex distal to an apex neutral or an apex proximal. So in other words, if you're going to change a patient from 1 to 3 apex distal to a neutral joint line, then you see that this has influences on your prompts and the patient is less good. All the other ones that they looked at, and this is changing a neutral to from 4, 5, 6 to 1, 2, 3 or to 7, 8, 9, this has no influence on prompts, and also 7, 8, 9, changing to other ones has no influence on prompts. So the main conclusion here was if you do this, this is something which is not good for the prompts. But this is just not what we are doing with Journey. We're doing, in fact, just the opposite. So again, we looked at the group of patients of Dr. Bollars in Belgium, because he had the prompts of these patients. What are the consequences if we change them? Like here, big valgus into 0 or 1 or 2 degree, so they become neutral, or if we change the joint line orientation. And they were looking at all these scores that you have over here. Of course, it's a very small group, but it's a start, and it makes us think that we have to look into that direction. So we didn't see any different in prompts going from 3, 6, 9 to 2, 5, 8, or we didn't see any difference from 4, 5, 6 into 1, 2, 3. So this is why we are changing, saying instead of keeping them in the box, keep them close to the box. Yeah? So this is something that we really have to look at now. What about the prompts if you do change them from one box to another box? That's something different, of course, as what you see over here. Yeah? So if you have a patient sitting in group number 1, and you're going to change him after surgery into group number 8, that's a big difference. Yeah? And just to show you, we are working now in a different way. So this is a patient that came in with a surgeon after surgery, primary knee. This was pre-op, and this was post-op. And that patient has never been happy from the beginning. So he had problems, pain, not well function. When they're looking at all the examinations that they could do to see what is the reason why that patient is not happy, they couldn't find anything. No infection, no allergy, well fixed, all these things were fine. Until the moment that the surgeon started to look at what about the CPAC classification that we have now. And if you look at it, he ended up with the classification 8, and he came from pre-op from a classification 1. So this is much too far to change him, and that might be a kind of a reason of thinking why that patient is not so happy. same here. I don't have the pictures of this one, but the same here. The patient was preoperative sitting in type 4, and postoperative he was brought into a type 6. So that means that this is a patient who have more than 2-degree varus, preoperative, and postoperative he was brought back in more than 2-degree of valgus. Yeah? So then you can think, perhaps logical that this patient is not really very happy. Yeah? So people start also to use CPEC classification to look at, can it support us also for the reason for revision in these cases where it's not really clear what the problem is in these patients. So this is a slide I got from Professor Ettinger, the boss from Dr. Savov, and this is how it might look in the future, how to have a successful knee. That people are going to look at the CPEC, so to decide how was that patient before arthrosis started, where is that patient coming from, pre-arthrotic. Then they're going to decide which implant are we going to use. They're going to decide which philosophy am I going to follow, mechanical, functional, kinematic alignment, and then they have a planning, and then they're going to execute the planning and hoping that this will lead to better results as we see now. There's a very nice video on YouTube from Johan Ballemans. So he developed CPEC together with some guys from Australia and one guy from the UK. It's available on YouTube where he is explaining the 2 groups I said here, every of these groups. So the 9 groups, you can see very clearly how he calculates for group number 1, group number 2, 3, all 9 of the groups. So it's really nice if you're interested to have a look at it and learn more about it. Thank you.
Devíamos ir para a discussão agora, mas o tempo já foi ultrapassado. Vamos saltar a discussão, infelizmente. Agora devia entrar a nossa colega de Madrid, Isabel Klein, mas ela não está ligada. Felizmente temos backup a apresentação dela gravada. Vamos ter que apresentar assim, peço desculpa. Mas vamos passar então para a próxima apresentação.
I am Isabel Guillén, a doctor from Clínica Centro. I am orthopedic surgeon, and it's a pleasure to stay with you and to share with you my experience with the Marco. Sorry, I can't go to Portugal. I think that it's a pretty to can't stay with you. But finally, I try to share with you my experience and the experience of my team. And if we have this question, how did we get here? Okay, we can beginning in 1996 when Professor Guillén, our boss, went to Germany, and he are thinking about the possibility of the robot in orthopedics. This robot was very curious because and very precision, and he can cut only the cell without cutting the cuticle. Very important, no? And very precision. But if we are speaking about the arthroplasty, we need to know that it's a very safe process. The satisfaction of our patient is 70% or 19%. And the patient finally has less pain and more functionality. So what is the problem of this prosthesis? The failures. The failure is the infection, the allergy, or release. The infection and the allergy, we can't do many things, but with the release, I think that in this point is the point that we can improve with the robot experience. Why? Because the release is because we are put the arthroplasty in a bad position with a bad alignment, or if we choose the size of the prosthesis bad. So then we thought that the Mako or the robot can help us in this release. And in November of 22, a very difficult year in our work because it was a COVID moment. But finally, we do all the workshop to learn about the MACO, and finally, the workshop is in the operating room for the nurse, for the doctor, and for all the hospital. Finally, we began with a MACO robot in November of 2020 for the total knee. In September, we bought the software of partial knee, and in May of 2022, we began with the hip procedures. Then, what is the option for the patient?
Can you hear me
the
now?
patient can choose with robot or without robot. But in
It's
the
Dr.
end,
Snare. Can you hear
the
me now?
patient wants experience of the surgeon, the precision, and honesty. And the MACO system components is a robotic arm, this one, the camera, this one, and the computer. This is the three components of the MACO. Before the surgery, we did a CT.
The first purpose of CT landmarks is to establish a new patient-specific coordinate system. With all CT landmarks selected and the new coordinate system defined, the CT scan and 3D model are then reoriented to be displayed plainly.
So with the CT scan, we can know we can know the size, the alignment of the leg, and a good position. And then the implants in the bone before to begin. But what is the limitation of the robot? Because the robot is not perfect. The first limitation is that if the doctor can't do the procedures, the robot doesn't do anything. Okay? The robot needs us, very important. And the limitation is the rotula is we need to do by the hand, and the PS box too. We don't have a components for metals allergy. We need to use other type of arthroplasty. When we need to use a femoral augmentation, we can't use MACO because MACO can't have. We can't do this process, but we can do the procedures for the augmentation of the tibia, but not for the femur. And we can use again for the revision arthroplasty. It's very common that all of you ask us about the time of the surgery. Okay, now the time of the surgery is the same than before. Okay, but then by hand. But in the beginning, the time was more time. We spend more time than now. For this, I recommended you that if you can do 2 teams during the surgeon did the approach, the MACO assistant or the nurse can do the procedures of the robot or the assistant, no, or robot. Then we have a third step, very important. In the first step is pre-surgery. The CT scan to the robot is the CT scan of the patient, and we send the CT scan to the striker, and striker begin the study. The second step is during the surgery, and is when we do a 3D model. We can see here, and later I show you a video about this. And this is when we did the 3D model, and is when the robot mix the information with the CT with the information of the 3D model during the surgery, okay? And the third step is the balance ligament. And then we decide the size of the components and the cuts. Okay. Now here we can see the moment that we are moving the knee during the surgery, and we can see the ligament. And this is the moment that I decide if I want CR or PS. The first step is to introduce the arrays in the tibia and femur. And now the decision is between the surgeon and the MACO assistant. When we have the 3D model, we have the rise and we have the CT before, and we have all the information. Until now, it's the same than the navigation, okay? With the navigation, we can find more or less this information. Then the robot guides the surgery according to the preoperative plan. But the preoperative plan, during the surgery, we can adjust according to the ligaments, no? The stability. And it's very important to see here, this is a video, summary of the video of one patient. This is the CT that we can see before the surgery. This is the 3D model that the robot has before the surgery, before to begin. Now, this is the surgery. I am here, and this is the arise for the tibia and femur. Yes, it's very important to do properly this in this moment. And now with this point, I can see here, this is the 3D model, okay? I am here to put the pin in the exactly part of the 3D model, and then this is the correlation between the CT and the reality 3D model of the patient. And finally, now I am look the stability, inflection and extension, medial and lateral. We can find the stability in different position. Now we are here, I can see properly, this is the blue, right? We can see the stability, the laxitude in the lateral in extension, in the lateral inflection, medial in extension and medial inflection. And then we are looking here the possibility to change a little the cut to obtain the zero, that the zero is the best for all, no? Because it's the zero is the perfect alignment and the perfect stability of the knee. And to find the best position, we can change the external rotation of the femur or valgus or varus of femoral component or tibial component, depend of the situation. Now, look, I am here to speak about here we can see the alignment of the leg. And when we obtain all of the information about the knee, I can do the best solution. It's very common in these procedures that we don't release any ligament because we can cut more or less and we obtain stability without release the ligaments. And this is the moment that the robot cut. This is a very good moment. And this is the difference of this robot to the others. In this robot, you can see here the arm do the cut daily. You can see me here. I can do only to go inside or outside, but we can't move for the lateral and we can't change the position. And I can show you, because during these procedures, I am looking the computer, but I don't look the knee. It's very difficult, and it's like a arthroplasty, no? Because I saw the computer, not the knee. And this is other example. Here, I am looking the computer on this other. You can see here the robot. The robot have a limit. In this other video, you can see here, this is the anterior femoral cut, and this is the guide. We are in a way, we are in a guide, and I can't go out of this guide, of this red line. You can see here the red line, and this is very safe for us because we can't cut a ligament or other structure like a artery or something like this, because when you are in the end of the cut, the robot stop directly. It's not possible to go out. It's not possible to cut anything more. You are in this way, only in this way. It's very safe for us. Okay, this is finally, in this case, was a C arthroplasty. This is our team. We are using the macro procedures in total in the unicompartmental, medial, lateral, or bicompartmental, and in a femoral patellar for the knee. And in the hip case, the macro is very important in 3 moments. When you have a dysplasia, because we can do the study before the surgery very good. The dysmetries, because with macro, the length of the leg is perfect, and we don't have a problem with the length. And when the patient have a lumbar diseases, because the macro study the mobility of the lumbar back, and then we can put the hip when look the lumbar disease. This is our numbers in the Clínica Centro. The Clínica Centro, we have now 1,500 cases. The most common is a total knee replacement, but we have 69 cases in unicompartmental knee and 95 of hip replacement. What is the best for the patient? The best for the patient is the recovery. The recovery is very soon. The patient has less pain because we don't release the ligament, and the blunt is less because we don't open the intramedulla bone. This is our cases. This is a case with femoral patellar replacement. And if the macro is very good for all the patient, the most important patient is in this case, no? The case that is very difficult to have a reference of the bones. And then with the macro, we don't need, we can go directly because the CT scan have a study, and in the end, the result is better. This is our other case that is a bicompartmental procedures. This is a very young patient, and he's very happy. And when we have a deformity in femur, in this case, the patient have a deformity, have a malalignment, and then we need to do a surgery, but it was very difficult. And with the macro procedures, finally, we have a very good results, and with a surgery less, in the surgery, we have more bone than in the other possibility. This is our team, and take-home message is this patient with macro increased the knee replacement by 40%. Now the macro procedures in our clinic is 74%. Our patients have more satisfaction, less pain, and quick recovery. For us, we are satisfaction. We have a satisfaction is more safety for us, and we obtain better position of the arthroplasty. And for the clinic, it's a marketing procedure. Is true. It's a technology at the service of the patient. So finally, I want to share with you what is our opinion about to introduce the macro in our clinic. And finally, in the beginning, we are expected about the procedures. No, we thought that macro robot in our clinic maybe is too difficult to do for the patient, for the doctors, and in the end, it's easy to implement in the hospital. I think that is a small learning curve, less than the other procedures. It's very safety for the doctor and very accepted by the patient. Thank you very much, and I see you soon. And later we can discuss about the procedure. Thank you very much.
Bom, agora temos em linha o nosso colega, o Dr. Nimrod Snir, que nos vai falar da sua experiência com o VELIS.
Can I share the screen?
We are listening to you, yes. Can
You need
start?
to allow me to share the screen.
Sorry?
You need to allow me to share my screen.
We
please.
are seeing you.
Good. Is that okay?
Okay now, yes. Thank you.
Okay, so let's see if we can. Are we good? Can I start? Hi. Okay.
Yes.
So thank you very much for inviting me. My name is Nimor Snir, and I'm going to talk about patient-specific alignment utilizing the VELIS assisted technology by J&J. This is where we're located, and you're all invited in Tel Aviv, like 500 meters from the beach. And I'll go over a little bit of my journey on total knee and technology, and then we'll talk about the characteristics of patient-specific alignment. We'll talk about our experience, how we position the robot, and patient-specific alignment with the VELIS, some surgical technique videos, our learning curve, and data collection. And then if we'll have time, we'll talk about the cases and some discussion. So let's start. So I started my journey with total knee and technology in 2006 with a frustrating experience during the first generation of navigation. And we deserted it in 2011, started utilizing the Mako for the unis and playing with the Ortho sensor. In 2019, we decided to change our philosophy from mechanical alignment to alternative alignment, and we wanted to be sure that we're not doing any mistakes, and we started utilizing the BrainLab Knee 3 navigation with a patient-specific alignment technique. And since 2022, I think February, we've been using the VELIS. So not all knees are the same. I'm sure that the knee of LeBron James doesn't behave the same as the knee of a small Asian female. We've been making it a little bit easy for ourselves, talking about the coronary alignment, and we're getting more and more information, but we're having less information on the sagittal plane, on rotation, on laxity, and on the patellofemoral joint. So we're in the beginning, I think, just starting to understand the knee. I'm not going to talk about the coronary alignment because it's been discussed widely. But technology is here to stay for sure. And according to a recent analysis on global markets, the penetration of new technology with emphasis on robots in the OR is exponentially growing, especially in orthopedics and especially in arthroplasty. And we all know the problems of that some of our patients are not as happy. Is it alignment? Is it soft tissue handling? Is it implant design? And maybe we're having a bad day in the OR and our precision and accuracy are not as we want. For sure, patient selection and characteristics should be taken into account. So at least for me, we're now at a very interesting crossroad after almost 30 years of stagnation in total knees. For the last 5 to 7 years, we're struggling almost like with the perfect storms. Most of the companies have new design of implants and materials. Everybody all over the world are rethinking of alignment. Is mechanical alignment still our goal, or should we go to alternative alignment? And kinematic alignment, PSA, anatomical function, they all have interactions with each other. And for the first time, I think computer-assisted surgery is really assisting the surgeon in the OR. So I'm going to talk about our experience with a tune implant by DePuy, utilizing patient-specific alignment technique with a VELIS robotic assisted solution. So we started with, as I explained earlier, we started with 400 navigated knees with the patient-specific alignment. And since February, we've done over 220 cases of robotic total knees with the VELIS. It's a semi-active, imageless, table-fixed robotic TKA solution. You can implement whichever technique you want or sequence you want. If you want to do mechanical alignment, that's fine. If you want to do kinematic, if you want to start with the femur or the tibia, you can design and decide which sequence you want. There is no need for pre-op imaging except I use the long-standing X-ray in order to evaluate the coronal alignment. It connects to the bed, so it has a very, very small footprint. You'll see pictures in a couple of minutes. And the saw is very, very rigid. It's 2 millimeter thick, and it allows you to have very precise cuts with immediate feedback, because you can do a verification and validation after every cut. This was published recently in Journal of Arthroplasty. So 2 slides on what is patient-specific alignment. It was published by Clatworthy and other surgeons from Europe, from Belgium mostly. It's an anatomical cut with the tibia first. In most of the cases, no soft tissue release is needed unless there is a severe deformity or bone loss. It's a kinematic alignment with minimal adjustment, and it does have boundaries, so it is restricted. We started with 3 degrees of boundaries on the tibia and the HKA, and now after almost 600 cases, we're up to 5 degrees on the tibia and on the HKA. The most important thing is that in the end, you want to be balanced in extension, so medial lateral is equal, and you want to have the MCL tight through the range of motion with a little bit laxity on the lateral side to allow deflection and posterior lateral movement, posterior movement. And if you can see on Dr. Clatworthy from New Zealand published on that he had better results compared to mechanical alignment. The resection on the medial and lateral tibia are identical, so the joint line obliquity is restored. We compensate for cartilage loss, of course, and the medial distal femoral resection equals to the thickness of the femoral implant, and that's how you restore the joint line height. These 2 things are very, very important to reconstruct the coronary alignment. And the only issue is that we haven't talked about a lot about in this meeting is on the sagittal plane. We try to do the tibial slope parallel to the natural slope of the medial tibia, but we know that on the medial and on the lateral tibia we have different slope, and we know that there's a huge variance between positive to up to 21 or 25 degrees of posterior slope. So it is an evolving technique, and we can talk about it later. So this is how the patient is positioned. I work in front of the knee, so it allows my assistant to stand on the side of the robot. And this is the robot. There are 2 options. One is connected before draping, and one is connect during draping. We don't recommend not connecting the robot to the table, but it is an option. So this is how it looks when you're connecting to the table. It's very, very small, and it doesn't interfere with the flow of the surgery. Another option is connecting it after draping, and this is how it's done. You do it usually, it takes around 30 seconds. Meanwhile, the other things are running around and doing all the necessary things in order to start the case. I mark on the floor. You'll see with a line on the floor exactly where I want to bring the robot in. So it's high-tech meets low-tech. So we start the surgical technique. It's the first part is exposure, and then one of the most important part is removal of the osteophytes. You have to go under the MCL, on the tibia, and on the femur, taking the osteophytes from the knots. It takes you a minute or 2, but it's very, very important in order to really understand the laxity of the knee. And then you position the rays. I position the ray inside the wound on the femoral side and distally on the tibia outside the wound in order to have, if I want to have a small stem on the tibia. And then you take it through the range of motion and you do accurate registration. You put stress of varus and valgus. you get the alignment, you get the laxity through the range of motion, and then you can do the planning according to what you plan on the long-standing X-ray. And then you do the first cut. It's a tibial cut first. You do the cut. I'm sorry, I'm hearing somebody else. You do the cut, the tibial cut. It's a very quick cut, and then you take out the menisci and osteophytes, what you can get. And after every cut, you do verification to be sure that you're not off what you planned. And this is probably one of the major things that changed the way I do my surgery. This is a tensor that I put it in, I relocate the patella, and then I take it through the range of motion from flexion to extension, and I have an objective soft tissue tensioning through the range of motion. I'm sorry, can you hear me or?
Yes, we are hearing you perfectly.
It's okay, I'm sorry. So then you have an objective soft tissue tensioning through the range of motion from deflection to extension, and mid-range instability. You can check it in this part. You take it through the range of motion. You see the graph. You can see it on the right side. And then you decide and do a secondary intra-op planning. You can do small adjustments in order to compensate for the sagittal change, and you can change the femur on all parameters, including flexion of the femur, varus valgus, distalization, up and down. And then in the end, you just do, you complete the cuts. As you can see, I have one assistant with me, and I have a scrub tech that is not doing a lot because there's no jigs and no needs for pins and other things. After every cut, you do the verification, and then, as you can see now, and then you just go and do the final evaluation with your trials. You get the alignment, you get the stability during the range of motion, and you get the stability from extension to flexion, mid-range instability, and you can evaluate your work if you want to. If you need to change anything, that's the time that you can do that. So regarding our learning curve, it's a relatively very short learning curve on the operating the robot. It's our first 5 cases took us 52 minutes from incision to final trials, and then it's after 20 cases it was down to 37. Now it's around 29-30, which is very similar to what was published by Dr. Clatworthy and a group from Richmond. And it's even shorter now than the navigation after 40 cases. The registration time is down now to 90 seconds, but you really have to be accurate on that. If you put garbage in, of course, you'll get garbage out. Out of the 220 cases, 6 cases we had to abort due to malfunction. 4 were at a very early stage in the old software. One was raised, one of the rays moved, and one was a handpiece malfunction. Today we're collecting our data over 200 cases on alignment, on long-standing X-ray. We're getting prompts. Looking at our complications, and we're comparing instrumentation versus navigation versus robotics, and looking at our learning curve. We're looking at limb alignment with PSA that is not only in the knee, but how it affects the ankle and the hip joint, and on in vivo accuracy. In a month, we're going to present it in the Hip and Knee Society, 3 papers on that. And I have to say that we're very encouraged by the results. So we're going to go over a couple of cases. This is a 75-year-old female that started with an HKA of 164, and because it's a restricted kinematic alignment, we brought it back to 175. Similar case, but not. This is a patient that started with a 175, and we left it with 175. One of the things that we learned that the when the cases become more and more complicated, it's better to use the robotics. And this is a case of a patient, a young patient, 43-year-old female, had a post-traumatic tibial plateau fracture, a femur fracture. She was very, very stiff until we took out the part of the hardware, and then the whole characteristics of the knee changed, and we could evaluate her laxity with the robot. And this is a valgus case of a really, really short patient, 135 centimeters, that I did a bilateral hip high riding DDH on her. She's a very, very short patient. We corrected the HK from 196 to 181. I don't like to leave them in valgus after the surgery, especially if the other leg is not in valgus. This patient's major problem was after an HTO and a multiligament reconstruction. The problem was on the sagittal plane, and we had to compensate on the sagittal plane because we couldn't put the tibial implant in 25 degrees of posterior slope. So we put it in 3 degrees, and then we had to compensate, small compensation on the femur in order to balance the knee. This is probably our first revision that we did. This is a patient that had a uni 6 months out. She fell down the stairs. She broke her hand, but she tore ACL, and she dislocated her menisci, and then we revised it with the robot. We left the implants inside. We did the same technique, and in the end, this is the end result. And we measured the proximal tibial angle according to the other side. So in summary, it's at least for me, it's definitely a new era. I think technology is here to stay. Personalized alignment is the future. Maybe with all the robots, we're going to get the big data, and that is what going to do the fine adjustment that we need now in all our different techniques of alignment. VELIs allow to perform alternative alignment in a controlled manner, in a safe manner. We're very, very accurate according to our studies on what we plan is what we get, and it just makes it really, really easy. And that's all. So thank you very much, and I hope to see you soon in Tel Aviv. Thank you very much for inviting me.
Thank you very much, Dr. Sneer, for your presentation, for your time. Hope to see you 5:30 your time for discussion, if you can. Okay, now we are going to lunch.
All right, just a second.
Thank you very much. Are you listening to me?
Yeah.
Thank you for your presentation. Hope to see you 5:30 your time for discussion.
Yes.
Thank you very much. Vamos almoçar? Tentar estar aqui mesmo às 2 certas, para não termos que deixar de fazer a parte mais interessante, que é a discussão.